Hello, hello. Mic test.
radiology, hopefully. So we have an interesting mix of cases. Okay, we promise to keep you awake. There's a lot of there's a lot to learn in this session. We'll be introducing you to a few tricky bits of radiology, and I hope you guys enjoy this. I'd like to call upon our chairpersons, and I'm so thankful to have this pleasure. A dear friend and an absolute gem of a person, Dr. Zubair Kazi from Safi Hospital, Mumbai. We're so happy to have you here. And then we have the next radiologist, our chairperson, the very, very enthusiastic Dr. Karuna. I'm so happy to have you here from Hinduja Hospital, Mumbai. So we have Mumbai chairing us. Mumbai Indians.
Good afternoon, everyone. I can see the hall is full, as Basita said. The tummies are full, and now everyone is thirsting for knowledge. This is definitely going to be an interesting session on sports injury, because it's not only about what we as radiologists see, it's what the sports person and the treating physician expect. Shani Agarwal, madam. Medical and Quality Officer at Amrat Private Limited. There's over 60 publications and 100 plus presentations at national and international conferences, and a core area of interest is MSc.
Clavicular joint injuries in athletes. These are the injuries that are frequently missed by us. So let us just look at the anatomy a little bit so that we understand what this joint is all about. It is a diarthrodial joint between lateral clavicle and medial acromion. Just remember, it is not a ball and socket joint. It has a wedge-shaped fibrocartilaginous disc, but it is not a ball and socket joint. It is weak, strongest in its supero-posterior aspect, where trapezius attaches to the clavicle. Then we have dynamic stabilizers and static stabilizers. Dynamic stabilizers are deltoid and trapezius, and the static ones are acromioclavicular ligament and coracoacromial ligament. Just remember that the acromiohumeral ligament is not a static stabilizer for AC joint. It protects the shoulder joint. It prevents superior migration of the humeral head. So we have this diagram, very nice diagram, showing you what the AC joint is all about. So there are acromioclavicular ligaments, the coracoclavicular ligaments. You can see that there are two parts to this coracoclavicular ligament. The medial one is the conoid part, and the lateral one is the trapezius part. And then you have the coracoacromial ligament, which is a protector of the shoulder joint. On the frontal view, it may appear vertical, but also it may slope downwards and medially, with the clavicle overriding the acromion by about 50 degrees. The exact role of the meniscal disc is unknown. It degenerates by 4th decade of life, and when it is present, it is usually incomplete. So on the radiographs, what do you see? You have to look at the alignment of the distal end of clavicle and the acromion. They should align together, and only then you can say that the acromioclavicular joint is normal. Look at the other side. This alignment is not, the two parts are not aligning together. And then you have to look at the coracoclavicular distance, which is normally 10 to 14 millimeter in normal individuals. And if it is increased, then that means there is something wrong with the AC joint. So we cannot ignore it, because it is an important component of the shoulder girdle, and provides a connection between scapulohumeral motion and the clavicular motion. Sorry. It acts as a strut between the upper arm and the axial skeleton. Remember that there can be a 6 millimeter translation in the anterior, posterior, and superior directions, and it rotates by about 5 to 8 degrees with scapulothoracic motion and 40 to 45 degrees with shoulder abduction and elevation. As I've already told you, that coracoclavicular ligament is the main stabilizer at larger degrees of separation, prevents superior inferior translation, and has two components. It forms a V shape, and these two components are separated by a bursa or fat. The conoid part prevents anterior and superior displacement, while trapezoid resists posterior displacement and multidirectional forces. Mechanism of injury is direct force or indirect force, and rare downward pull from a heavy load. What are the physical signs? Very easy to remember. There will be a visible deformity, and on palpation there will be tenderness or deformity. Then there is a piano key sign, which is superior inferior translation in severe injuries, and as you shrug the shoulder, it helps differentiate between grade 3. We'll look at these grades later. Grade 3 versus grade 5. And with closed manipulation, if it is reducible, it is grade 3. And if it is non-reducible, it is grade 5. It accounts for 12% of all shoulder injuries. And this percentage is likely to be an underestimation because minor injuries are often overlooked. 40 to 50% of injuries in contact sports are generally ACJ injuries. Highest incidence is in the younger generation, and 5 times more risk is noted in males. So the first modality of choice is the radiographs. So what are the radiographs? The AP view. Zenka view is AP view with 10 to 15 degrees cephalad angulation to isolate the AC joint. Axillary view, predominantly for anterior posterior displacement. And stress view, you stress the joint, and that differentiate between grade 2 versus grade 3 injuries. And the key metrics is if there is 25 to 50% increase in coracoclavicular distance between the two joints, then it is a complete coracoclavicular ligament disruption. So these are some of the views. Generally, as I said, the coracoclavicular distance is 10 to 14. It's about 9 millimeter here. And this is the Zenka's view. And with the stress view, it increases to about 14 millimeter, which is still normal. And then you have the axillary view. This is the AC joint here. This is the AC joint here. Role of CT and MR is very limited. And it is only used for complex fractures. MRI is not routine, and it is best for soft tissue evaluation. It can detect ligament tears, muscle injuries, and adjacent structural damage. And it may upgrade injury severity compared to clinical and radiographic grading. So this is an MRI, predominantly used for soft tissue injuries, better seen on MRI than any other modality. And you can also do an ultrasound. Nowadays, ultrasound is being done for every MSK pathology. You can see that there is mild subluxation of the AC joint on the right side. I had a little fun with my co-pilot and I created this. So it is type 1 is just a sprain of AC joint. Type 2, the AC ligament tears and there is sprain of CC joint. So that means in these two injuries, your radiographs will be absolutely normal. In these two cases, in the first grade and the second grade, the clinical findings will help you decide whether the AC joint is injured or not. And then in type 3, there is AC and CC ligament tear. Here, the coracoclavicular distance will increase. Then type 4, 5, and 6 were added later by Rockwood, and they just define the displacement of clavicle with respect to acromion. So in type 4, it is displacement. In type 5, superior, and in type 6, it is inferior. So, it is widely used, but remember, it is not a linear system. Just because somebody's graded it as type 6, it doesn't mean it is the most severe of injuries. It is severe compared to type 1, but it is almost similar to the other 4, 5, and 6 are of the same grades. So grade 1 to 3 and 5 follow severity continuum, and grade 4 and 6 represent atypical displacement patterns. And the practical division is between, you have to decide whether to operate on these joints or not. So the radiographs are more accurate. For type 2 can be diagnosed by the stress view, type 3, type 4, type 6. Remember, type 4, which is the posterior displacement, will be seen only on the axillary view. And then you have to remember to look for associated injuries. The distal clavicle or acromion may be fractured. There might be avulsion fractures at ligament attachment. There might be post-traumatic osteolysis of distal clavicle, and there might be muscle stripping from distal clavicle, which will be seen on MRI. So, clavicular fracture in the first radiograph and coracoid fracture in the second radiograph. Okay, some examples. So, mild widening of the acromioclavicular distance. In this, there is overlap and increase in the coracoclavicular distance. Again, overlap in this, and then associated clavicular fracture in this one. Treatment overview depends upon, goals are that there should be no pain. There should be recovery of strength, and there should be return to activity. It depends on injury grade and what is the occupation. Can the patient take it? Can the patient live with it on a long-term basis? And what are the expectations? And what is the physician preference? Sorry, just 2 minutes. Grade 1 and 2 are non-operative because CC ligament is intact. Grade 3 is controversial depending upon what are the conditions. And grade 4 to 6 are typically surgical, though non-operative non-operative options are possible in selected cases. So surgical options are, it just got switched. So we don't need to see the surgical options. The two got switched. So in conclusion, the AC joint injuries are frequently missed. Please look for them if it is clinically evident. Careful clinical evaluation is necessary in suspected cases. Radiographs are the modality of choice, and it is important to do stress views and axillary view in suspected cases. And cross-sectional imaging is required to evaluate the entire extent of injury before operative intervention. Thank you.
There is a big role of stress radiography. And remember that when you do an MR, and if you think this is a Rockwood 2 or a Rockwood 3, think again. You see edema in coracoclavicular ligaments, and you're not going to see them torn apart like this at a gap. So it's important to do a stress radiograph where you can have 2 to 4 kilos in both hands, keep the patient erect standing, and you'll be able to differentiate the various kinds of Rockwood classifications, which was primarily an X-ray based Rockwood classification. All right, and you'd be able to say the grade, because in MR we strap the patient up, so everything reduces. Okay, so just something to remember, that don't be very confident on Rockwoods. I've seen things go up and down, so always couple that with a stress radiogram. Okay.
Thank you, Dr. Nafisa. Now would like to invite on stage Dr. Arjun Narula. He's a consultant radiologist at Narula Diagnostic Center, and his core interest on MSK imaging, image-guided interventions, advanced pediatric imaging, and cardiac imaging.
request all the speakers to stick to the timing if possible.
Absolutely, sir. We'll keep it short and sweet. Very good afternoon. So quickly we'll talk about slab tiers. So of course 10 minutes, a little less a bit of time. I'm going to go through what difficulties I face as a consultant, which you might face as well, and help you solve those problems efficiently. Everyone knows what a glenoid labrum is. We know the imaging planes to be taken, axial, sagittal, and okay. This doesn't go from my time. 1 second. Just give me 1 moment. Yeah, okay. It's coming right here. So sorry about this. Connect हुआ है choose content ठीक है entire screen कर देते हैं ये सब pendrive ले लेते हैं yeah. So quickly we'll talk about the challenges I face as a consultant during reporting of slab tears. So everyone knows what a glenoid labrum is. It's a fibrocartilaginous structure which deepens the glenoid cavity, gives movement and stability at the same time. So how do we plane the images? We take an axial and we plan the sagittal and coronal along the glenoid labrum, perpendicular and parallel to it. The sequence is predominantly PD weighted. Some like it PDFS, some like it PTVD. You add a dash of coronal T2 and a coronal T1. What is interesting is the role of 0T imaging. Quickly ask how many of you are doing 0T imaging in their clinical practice? Yeah. Aniket, I think many people are doing it here. As of now, we have done across more than 500 patients with 0T imaging, and I have a strong opinion that we are not there as yet. We are learning from it. We don't know how much clinical value we have in it. We do miss small Bankart lesions, and in knee specifically is doing very well. So I think as you go along, it will become a normal ritual for all the scans that we do. Quickly about how we position the patient in the Aber position. How we classify is a classical clock from 12 to 12 o'clock, anteriorly and clockwise. We can also call it superior, inferior, anterior, and posterior, and so on. Before we pick up any pathologies, we have to be sure that these are not anatomical variants. For that, we should know the variants of the labrum, the superior labrum, the labrum as such, and the glenohumeral ligaments. These three anatomical variants need to be ruled out before we call any pathology a pathology. So biceps labral complex can be 3 types. It can be tight attachment, loose attachment, or with a very nice loose sulcus between the labrum and the glenoid cavity, as we can see in these images. Second most common is actually a sublabral recess. It's actually a small crescentic recess between the glenoid cartilage and the bony labrum. Classically, it's very crescentic shape, is smooth, it's very organized. That's how you differentiate it from a tear. It is usually very limited to between 11 to 1 o'clock, and a tear extends beyond it. That's how you differentiate. The more and more cases you see, it becomes easier and easier to differentiate. When the labrum becomes a little prolonged and drooping downwards, that's when we call it a meniscoid labrum. This is quite rare. A sublabral foramen is when there's a failure of attachment. We see a we can see hyperintensity between the labrum and the glenoid cavity through and through. And force, we can see this in all planes. And the most common or uncommon variant is the Buford complex, the absence of labrum in anterior superior aspect. It is typically accompanied by a thickened MGHL. That's how you are more confident in calling it a Buford complex and not a absent or a torn labrum. This is my beautiful drawing, just to represent the same. If you like playing with iPad, you should do this as well. Now, this for the residents is a fancy word we rarely use in reporting, is a cookie and an Oreo cookie sign. So whenever there is a presence of a recess with a superior labral tear, we classically see a hyperintensity, hypo, and hyperintensity, which look like 2 stacks of Oreo cookies together. I think we all like giving fancy names, and this is just about it. Never produced it in my report, but just to know. Now the variants of the glenohumeral ligaments, all of us know the origin and the insertion, but there can be a variation in origin and insertion. Just follow the ligaments. The superior glenohumeral ligament may arise from the biceps tendon, may arise from the anterior labrum, can merge with the MGHL as well. Similarly, the middle glenohumeral ligament may classically have a widened attachment, may have a lower high insertion, which may sometimes give a classical appearance like this, that this is a stripped MGHL, but it's not. It just has a more medial attachment. Now, why is it important to classify and characterize these SLAP lesions? We have to think like a surgeon. What would the surgeon want? Kya chahta hai wo? He wants to know whether he has to manage this conservatively, he has to debride it, he has to resect it, he has to put anchors. What is it? So think like a surgeon. Just don't report whatever comes to your mind, and we follow the classical classification system. You should be ready to answer the call and answer what he's asking. So all of us know, according to Snyder, there are 4 classifications, 1, 2, 3, 4. We now extend up to 10 classification numerical terminology. But more important than that, it's important to classify. What is important? Kahan se kahan tak, from where to where is the tear going? Second, what's the morphology? Is it oblique? Is it through and through? Is it just fraying? So describe your labral tear in a very systematic way. Where does it start from? Where does it end? Is it involving any other structure in the shoulder? The glenohumeral ligaments, the biceps anchor, the rotator interval. That is what is important. Classification is important, but the description is of utmost importance. Even if you don't mention the classification, I think it's all right. Because just to understand and make our learning easy, we use this classification. SLAP 1 is simple fraying of the superior labrum without obvious tear. So as we can see in this, I took these beautiful diagrams from Radiographics article. Everyone should go to that article, it's beautifully explained. Sorry, this is type 1, just simple fraying. Type 2 is when it is associated with a proper tear. Type 3 is when there is a bucket handle component. Now we're talking about think like a surgeon. If the SLAP component is very small, a simple debridement is sufficient to ease the pain while not compromising on the shoulder stability. So yes, you should also mention the amount. I have started mentioning the approximate amount. I don't know how many of you are using it. I say it's involving about 30%, 40%, just to give a rough idea to the surgeon how much is the paucity of the fiber in that component. Type 4 is when it involves the superior biceps anchor. As we can see in this as well, there's a very nice cleft here, and we can see that the labrum is coming down like a bucket handle. Type 5 is when it extends beyond the superior margin into the anterior labrum. Again, this is the MR image of the same. Type 6, it's when you see a dissociation of the biceps anchor. This is very uncommon to see this type of lesion. Type 7, it's when it extends the MGHL into the MGHL. Type 8, 9, 10. 8 is superior to posterior, only the posterior aspect is involved. Type 9 is when anterior and posterior throughout the, except the inferior part, the entire labrum is involved. And 10 is when the SGHL is involved. Bottom line is, we need to be descriptive of what all is involved, and that's about it. So again, a very simple diagram in my beautiful drawing. And you just make a note of this, the labrum, the ring, and the attached ligaments, the glenohumeral ligaments and the biceps anchor. Keep this in your mind, and that's all you need to do. I think it's a very simple anatomy to report. Thank you so much, and I think we have 2 minutes for questions. I was applauding myself for this time,
You deserve a chocolate. Are there any questions from the audience, or would Dr. Nafisa like to add anything?
I have a few questions if anyone would like to participate, if that's all right. How many of you think that arthrogram is necessary for good SLAP tear reporting? Yes, Shairi, please. It's a very common debate we have at our center. What do you think? It's important? And what do you inject, still inject gadolinium, or just even saline is fine because GAD? So that's a very fair point. When you are very confused between an anatomical variant, yes. Yes. So first is you keep your orthopedician happy. And second, when you are confused between a variant and a tier, then yes. And ma'am, what do you think, Nafisa ma'am? Do we need to use gadolinium, or even saline is okay with, we just take good PD images and that's it?
Yes, I think if there's effusion in the joint, there should be no doubt at all. You can inject saline and you can use the GAD protocol as well. Remember that if you use more GAD than required, you will invert the images.
Yes.
So ask your technician, is it regular strength or double strength? I've seen people injecting the same amount, which is 0.1 ml, not 1 ml, 0.1 ml in a 20 ml injectate. And if you're using a double strength, it will flip. Instead of being bright, it's going to be dark. I think arthrograms are required when and only when this is the only reason why the patient is going to be operated upon. If there's already something else happening in the shoulder for which the patient is getting operated and you're not sure of the slap, don't get an arthrogram done, because the surgeon will go and see anyways. But if it's a young patient, a sports person, and this is the only reason why the surgeon is going in, you don't want a negative arthroscopy, so better go for an arthrogram. But having said that, we don't do many in our center, because with the 3 Tesla, we don't need that much. But still, you can be in a fix at times.
So I think Shari ma'am and Nafisa ma'am pretty much answered what I had in mind. This is the right way to go. We should not push it, but use it conservatively as a tool when we are confused and stuck. Thank you. Thank you so much. And one more thing I'd like to add, just very interesting thing, sir. I was an attendee in Ankur Shah sir's talk on slap lesions in 2011. And just a big round of applause to sir for that. 15 years apart.
Right.
Thank you.
Thank you, Dr. Narula. The next speaker actually needs no introduction. Dr. Ankur Shah is the organizing chairman of AMS 2026. And more importantly, he's a very passionate teacher with a very special interest in MSK imaging and especially sport injuries. Over to him for his next talk on stress injuries of the spine. Welcome.
Thank you, Dr. Zubair sir, for your all kind words. I'm sorry for but some of you might have to stand, but I learned from some of the conferences like RSNA that full hall is a sign of a relatively good session and good conference. So please, we are arranging a few more chairs, so at least some of you can sit. And if possible, we are trying to make some more arrangement for the later on sessions so that you all can watch more comfortably, you can attend the session. So coming to the topic, my topic is a fast bowler's nightmare, stress injuries of spine and side strain injury. This is one of the topic which I really love by my heart. We do a lot of scans of players, and many of them, though young guys, they are having stress injuries, and unfortunately they are very frequently missed. Cricket, we know it is a relatively safe sport compared to many other sports, and that's why we see cricketers in their even mid-30s and 40s still they are playing, because it has a relatively less injuries. But because of the repetitive sagittal and rotatory movements, the fast bowlers, they are at increased risk. Like Bumrah said, that all the batsmen, they are the prince and we are the poor laborers. That's what he used to tell me every time. So lumbar spine injuries, they are among the most common overuse injuries in the fast bowler, and the prevalence of injury is in disc degeneration, it is about 25 to 60%, and similarly the bony injuries are also as high as 24 to 81%. Fast bowling injuries, they are about nearly 50% of the total injuries in cricket, and what we see is mainly spondylolysis and listhesis, which is seen in about 24 to 55% of the fast bowlers in adolescents, and the risk is even higher in the younger individuals. These injuries, they require long recovery time, many times in months, and that is why it is important to recognize those. I'd like to show you 2 or 3 cases which will cover the spectrum. If you see at this lumbar spine, I'm sure many of you like us must be getting, at least in India, a request for screening lumbar spine, right? So this is what we get with screening lumbar spine. Can anyone identify any abnormality in this? Any abnormality? I'm sure nobody can, because there is none which is seen. On the second sequence, maybe some of you can. This is completely normal here. There are some arrows to help you. But so this is something, a lumbar pedicle stress injury, which will never, even in retrospectively, you can't see that on T2, right? So it is going to be completely normal on T2 weighted sequence. So one message is, please, whenever you're doing a scan of a young bowler or a young person with severe back pain, don't just stop at the screening of spine with only T2 weighted sequence. You need to take T1, you need to take one fluid sensitive sequence, STIR or fat set T2, because without that, you can't diagnose this early stress injury. If you don't diagnose this, he continues playing, he might end up having something which is as bad as this, right? So this is something which is in a worst case where it starts on one side, it is even going on the opposite side. You might think like what kind of trauma he had, but he didn't have any trauma. He's just a fast bowler who presented with such kind of a spondylolysis, which has gone across the midline to involve the opposite side. And you know this person very well who has undergone spine surgery as well for this. Can you see this spine now again? Can you identify something abnormal, something subtle? If you look at both the facet joints, the left is a little more hypertrophied than right. And someone, my mentor, he's here only in the conference, Dr. Shrikant Narayan Swami, whenever he used to get this scan, he calls me, is he a right arm fast bowler? And without history, he's telling me that, is he a right arm fast bowler? And I was amazed. Then gradually he taught me that look at this facet. When you see the asymmetric facet joint hypertrophy on one side, always think that if it is a fast bowler, it will be always seen on the contralateral side of his bowling arm, right? Not just that, you can see the sclerosis, much more on the opposite side. So in a fast bowler, if you look at both the sides, particularly at the L4 level, sometimes L5, you will see these areas of sclerosis, which is because of the chronic repetitive strain in a right arm fast bowler, you will see it on the left side. So there is greater mineralization of bone on the spine, on the contralateral side of the bowling arm, mainly at L4 level, and facet joint asymmetry. This will help you in giving that diagnosis of the bowler. Lumbar spine stress injury, usually we'll see at the posterior elements, at the neural arch, pars interarticularis, can be bilateral, unilateral, and usually on the contralateral side. Most players, they present with back pain, but that is at the acute symptoms. Once it develops spondylolysis, then he might become asymptomatic again. So you need to be more careful, particularly when there is a fracture. What are the factors that affect? An important one is bowling action. Why did Kapil Dev played for so many years? Malcolm Marshall played for so many years. He had a side arm action, he had a front arm action. But with mixed action, it is much more prone to develop these kind of injuries, apart from the excessive workload that current players are facing and some associated injuries as well as age. So this is what we see typically in a lumbar spine acute stress injury. Now you all are wise enough to identify this subtle marrow edema in the left pedicle of the L5 vertebra. Always look for this, because by just diagnosing this injury, you will be saving a career of a bowler. If you don't diagnose, he might end up having lysis, and then probably his spine is unstable, and there might be a complete pedicle fracture like this if this is not detected, not given enough rest at the time of acute injury. Again, a young cricketer, back pain. You can see there is already spondylolysis on one side, and the other side, it is an acute stress injury. So they are having many of the times bilateral injuries. One could be chronic, one could be acute. So do not forget to look at all these details whenever you are seeing the spine of a bowler. 20-year cricketer, nothing acute, but there is significant sclerosis. Now you all can make out in the pedicles as well as pars interarticularis, and that is a chronic stress injury at the L4 level. How do we manage that? Usually it is conservative. Acute stress injury requires about 8 to 12 weeks of rest. With once spondylolysis occurs, then he might take about 6 months to come back into the action, particularly when it is acute one. Chronic stress injury depends on the symptoms and by the modification of the activities. So many of them are asymptomatic, and it is just part of their repetitive microtrauma which occurs, and that is what we see on MR as chronic injury. And chronic spondylolysis, again, they can be asymptomatic, and just with muscle strengthening, they can continue playing. And unfortunately, sometimes it might require surgical treatment with pedicle screw. The other part is side strain injury. This is something which a physiotherapist taught me. He sent one patient and telling me that I'm sending a patient for the side strain, and many years back, and I was not aware. I had to Google it. What is side strain? And then I realized it is actually a clinical diagnosis when a patient, particularly a fast bowler, while playing, he suddenly experiences severe pain, mainly seen in fast bowlers, sometimes in javelin throwers also. The common site of injury is at the attachment of the lower 4 ribs. Rarely it can be seen in the pelvic bone attachment site also. Presents with acute onset pain and local point tenderness at that site. As I said, mainly the diagnosis is clinical, but MRI, it helps in evaluation. This is how it presents. Sudden onset of pain. You might have seen a cricketer while playing, he suddenly stops bowling and with severe pain, and that is because of the side strain injury. It occurs due to involvement of the abdominal wall musculature. Usually the muscle which are involved is the internal oblique or sometimes external oblique, but most frequently it is the internal oblique muscle which is affected. Can you compare on both sides? Here it is completely normal, and here can you see a big gap? So that is because of the acute partial tear. A focal segment of the internal oblique is completely torn and retracted, which is the classical appearance of side strain injury. All of these, you will see the muscle is significantly thickened. That itself tells you the person is doing having a very good abdominal wall muscle. They all are very well built with, we know, a lot of hard work that they put in. This is how it is seen on the fat suppressed images, which are most useful. You will tell you the edematous changes, sometimes mostly in the muscle. Sometimes you might see even bone marrow edematous changes in the rib at the attachment site, which is also a very frequent presentation of side strain injury with higher severity. Rarely you might see injury at the iliac attachment. So usually the attachment site is the ribs, but sometimes you might see the injury occurs at the iliac attachment where the insertion of the muscle, and that is also a part of side strain injury spectrum. Recovery time, grade 1 injuries are mild, which are with minor stretching of the muscle. With mild pain, they might recover in about 1 to 3 weeks. Moderate injuries with partial tear might require 3 to 6 weeks. And once it is severe with complete tear of the muscle, it takes significantly longer time of 2 to 3 months for them to recover. But as I said, usually the diagnosis is clinical. Our help or our requirement is mainly to tell them about the grading of the injury so that the rest can be planned accordingly. And as Dennis Lilly said, fast bowling is like a 100-meter sprint where you have to jump at the hurdle at the end of the 100-meter sprint. So it is genuinely a tough job, and that is why they suffer quite a lot of injury. Thank you so much for your patient listening. I'm grateful to Dr. James for being here for this session. He must be seeing much, much more, and I'm sure he can guide us much more on this. Thank you.
Would you like to add something to the points that Dr.
Firstly, congratulations on a terrific presentation. We scan a lot of the Australian fast bowlers, and the Australian cricket have developed a system where they like to look at the stir signal intensity ratio between the pedicle region and the vertebral body. And we did it on a sagittal stir sequence, and if that ratio gets above two, they'll start to worry, and they might be incident. And it's actually a predictor of being a disease, and it's a predictor they'll develop a fracture subsequently. And very much we see that pattern that the fracture begins at the inferior cortex. Rarely we see it at the superior cortex. But I can't add much more, and it was a terrific presentation. Congratulations. Thank you.
Thanks for your calls.
Thank you. So we do quite a lot of these. So we do vibe sequence, which is similar to 0TE, which is fantastic. As you said, the fractures start at the inferior cortex. There's a reason for it. If you go back and look at the spine again, CTs especially, you will see the inferior parts will make a triangle like an apex, and that's a stress riser. That's where the cortex breaks. That's the point I always see, because compared to the spondylolysis that we are used to, the sports-related ones are at the junction of the pedicle and the pars interarticularis. And if you can do, you should do vibe and 0TE. The reason being, the traditional T1 stirs we have are thick slices, and parts, especially at the stress rising L4-5, L5S1, are in an oblique fashion. So it's very easy you miss them. So volumetric acquisition and vibe.
On your machines, these sequences are available, and you can definitely acquire those sequences. Thank you.
It is my pleasure to welcome one of the great teacher, mentor, and inspiration for many radiologists, including myself, Dr. Sanjay Desai, sir. He is a consultant radiologist at Dinanath Mangeshkar Hospital and Research Center, Pune. And he's a founder of MSK Fellowship at DMH, along with multiple MSK online courses.
Thank you for the kind introduction. Hi, everyone. So today I have a very specific topic. So it's a sagittal band injuries, and how will you diagnose it on the MR? I have added a little bit of ultrasound because I feel ultrasound is much better than MRI in this, and a few pitfalls. So what is the sagittal band? So we are moving right from the spine to a very small area of the finger. So that is in the region of the metacarpophalangeal joint. So sagittal band, structurally it's a fibrous band which arises from the volar plate, that is at the volar aspect of the metacarpophalangeal joint, and it goes across the metacarpophalangeal joint and then envelops the extensor tendon of that of the joint and forms on both sides. So there is a sagittal band. Every finger has a sagittal band on the ulnar side and on the radial side. So you have two sagittal bands. The sagittal bands are there only at the level of the metacarpophalangeal joint. Beyond that, whatever is enveloping the extensor tendon is called as the transverse fibers or the transverse bands, and right through when it forms a kind of a tunnel, it is called as a dorsal hood of the finger. The sagittal band, basically because it's on either side, it's a little thicker on the radial side as compared to the ulnar side, because if you make your fist, you will realize that most of the stress is on the radial side. So it's a little thicker on the radial side as compared to the ulnar side, and it stabilizes the extensor tendon when you do finger flexion. So when you do that, the sagittal band has to be intact. So this is your level of the sagittal band here, and when you take a cross section, you will see that you will see a metacarpal head or the base of the proximal phalanx, and this black band is your sagittal band. So you have a radial sagittal band and an ulnar sagittal band, and it is enveloping the extensor tendon. So this is the extensor tendon of the index finger. So there are two of them, and this is the middle finger, which is just one. So whatever it is, the entire tendon of the extensor tendon is enveloped by this band. So you have the radial and the sagittal band, which is on the radial side and the ulnar side. So, and it is inserting onto the volar plate onto the volar side, and this is the extensor tendon on the dorsal side. So when you do it with the ultrasound, you're not able to actually see the sagittal band properly. It's a very thin band here, which is hardly 0.05 millimeters in thickness, but that's the level, and you basically have to analyze the ultrasound basis on the extensor digitorum which is centered exactly in the middle of the dorsal aspect of the metacarpal head. It can also be in the dorsal aspect of the proximal phalanx, but that's where it should be located on ultrasound. So when there is a tear of the, so there is one more thing, two more things that you need to remember. So there is the proper collateral ligament and the accessory collateral ligament, which is there in all the finger joints. So this accessory collateral ligament also inserts onto the volar plate, and the proper collateral ligament goes from the bone to the bone. And the thing to remember is both of them are deep to the sagittal band. So normally why I'm telling you all these in detail is you never usually have the tears of the sagittal band only. Most of them will extend into the adjacent collateral ligament and also extend into the joint to involve the metacarpal head or the proximal phalanx. So that's the usual pattern. So you will have to see the pattern from outside to inside. You may also see some pulley tears, which is again a closely associated structure onto the flexor aspect, and there is a structure which connects the volar plates of the adjacent fingers. That's called as the deep transverse metacarpal ligament. So all these things are interconnected and very close to each other, so most of them can injure with the other. So on the MR, we can see that these are the sections which are going axial. We'll see the axial sections going from proximal to distal. This is at the level of the neck of the metacarpal. You're just seeing the extensor tendon. The sagittal band has not yet started. When you go to the level of the metacarpophalangeal joint, you start seeing the sagittal band. So this is the sagittal band, this black thing which is going, enveloping the extensor tendon and then going to the other side. The collateral ligaments are deep to it. Now this is a PD and a PD weighted sequence, so you may not be able to see the structure separately. You may be able to see them on the PD fat side. So as you go further, you're going to the level of the distal part of the proximal phalanx. The sagittal band is not there in this location. What you're seeing here is the extensor hood or the transverse fibers. Further, it becomes a proper extensor hood and then goes and inserts onto the base of the distal phalanx. The same thing can be seen on the ultrasound. As I said, this is your extensor tendon. This is a sagittal band on the ulnar side. That's the sagittal band on the radial side. And this is the same thing which you're seeing in the in another finger. Now, MRI protocol for the sagittal band injuries, usually they will be seen in boxers, most of them, but we are also seeing them in people who are going avid gymmers, in people who go to the gym often. They also are now having a lot of injuries of the sagittal band. Field strength preferred is 3 Tesla. Coil, you should have a dedicated coil, that is better. If you have a smaller coil, it will be better to get high resolution images, because you will need resolution which will be possible at the field of view of less than 8 centimeters. So around 6 to 8 centimeters is a good field of view. Slice thickness, you should go to less than 2 millimeters if it's possible, but at least 2 millimeters. And positioning, I know it's neutral position is better for the hand in general, but when you're doing the sagittal band, try to have a prone Superman position, because in that position there is, if there is a displacement of the sagittal band because of a tear, that is better seen in a prone position. Sequences you can see in PD FATSAT or non-FATSAT, and sometimes we can use a 3D PD weighted sequence which is available on all the machines nowadays. So this is how you will see the sagittal band, the extensor tendon. This is the black sagittal band on the radial side. This is the black sagittal band on the ulnar side. And you see that the extensor tendon is relatively in the center. There is no peritendinous edema, no soft tissue thickening. This is normal. So when there is an abnormality of the sagittal band, we try to grade it. As usual, there are 3 grades. Most of the MSK has 3 grades. So grade 1, grade 2, grade 3. Grade 1 is just contusion. You have edema around the tendon of the extensor tendon and in the region of the sagittal band, but you will not see a focal discontinuity. In the partial tear or a grade 2, you will see some kind of discontinuity and some subluxation of the tendon. That is more visualized on the ultrasound as compared to the MRI. MRI can sometimes be normal in a grade 2 as related to the displacement of the tendon. Grade 3, you will see a complete tear, or you will see a hematoma, or you will see a leak of the fluid in that region, and then you will also see there is at least a subluxation, if not a dislocation. So the graded MRI appearances, you can see this is a grade 1 injury in which you are seeing that there is a contusion, but there is no frank discontinuity. In grade 2, there is discontinuity of the tendon and medial subluxation. On grade 3, there is complete dislocation of the extensor digitorum tendon here, and you can see there is a discontinuity and widening of that gap as well. So this is grade 3, grade 2, and grade 1. So grade 3 usually will have surgical intervention. Grade 1 does not require much treatment except for rest, and grade 2 is the thing which is really something that needs either rest and a follow-up to check whether it has healed or not. This is again another case of complete tear of the ulnar sagittal band. This is just radially subluxated but not yet dislocated, and this is more dislocation because of both the sagittal bands are torn in this. So you have a tear along the ulnar aspect also and the radial aspect also. So this is the diagrammatic representation. This same patient, when you see on the ultrasound, you see more dislocation of that tendon outside as compared to the MRI, because MRI you are doing it at rest. When you do it in more finger flexion, you get the dislocation better on the ultrasound. So this is a normal person. When you're doing an ultrasound, you have to do it dynamically, which you can't do on the MR. So this is a normal person, and we'll see what happens in these two. So this is the normal patient. When you do it, look at this metacarpophalangeal joint, and there your tendon is, the tendon over the metacarpophalangeal joint is stable. It is not going medially or laterally. But now look at this tendon here in a patient and the ring finger. So look at how it is dislocating. So that is a sagittal band tear. But I thought that I'm wise with this, but when I do this, you can see that in this patient all the 3 are dislocating. But this is not a patient. This is a normal person. This is one of my fellows. So this is the pitfall. So in lot of patients you have normally also there is a dislocation of the tendon. So dislocation of the tendon does not equate to a sagittal band tear unless the patient has a proper history regarding that. So this is the pitfall. So this is a normal person, this was a patient, and this is not a patient, but she has all the 3 tendons dislocating. So the same thing if you want to see on ultrasound. Can I take a minute more? So when you take it on the ultrasound, the tendon is dislocating laterally. This was not the fellow, this was the patient. So the diagnostic tips on the MRI is the tendon offset. So measure the displacement of the EDC tendon from the center of the midline, that is a metacarpal head. If the offset is more than 2 to 3 millimeters, then it's a grade 2 suspicious tear. More than that, it's definitely grade 3 tear, even if you're not able to see the actual sagittal band. Asymmetry of the band signal on the PDFS, that's usually for a grade 1 injury. Grade 3 is again seen as an empty groove sign. And look for associated injuries. As I said, isolated sagittal band injuries are very, very uncommon. You'll get collateral ligament tears, intrinsic tendon tears, or volar plate injuries. You can see these sagittal band injuries in acute trauma, which is technically called as the boxer's knuckle, but you can also see them in rheumatoid arthritis and sometimes idiopathically as in our fellow. The pitfalls on the MRI, you need to remember these things. So I'll just rush through them. Tenosynovitis you need to be very careful about, because you may feel that there is a tendon, there is a fluid around the tendon, and is it leaking or not? Is there a band tear or not? Ganglion compressing the sagittal band can be there. There can be septic arthritis, which needs clinical correlation and the DW images. Extensor tenosynovitis, any abscess around that area, and erosive arthropathy you need to rule out before you diagnose a tear. So radial limb tears are more common. EDC tendon position is your most critical reading parameter, especially when you want to differentiate between 2 and 3. 3T MRI with smaller FOV and less than 2 millimeter thickness sections will give you are non-negotiable for reliable diagnosis. Grade 2 versus 3 will be the main feature, because you want to differentiate between surgical and conservative management. An empty groove sign is your most reliable axial imaging sign. So see you again next year in Calcutta, and you're invited for the MSK intervention course in Mangalgiri in December.
Right, thank you Sanjay for an excellent, as usual, meticulous and well illustrated talk. Are there any questions from the audience, or would anyone like to add anything from the experience? I'd be happy to hear that. No? Thank you, Sanjay. Thank you so much. It's an immense pleasure to introduce the next speaker, a dear friend and colleague, Dr. Nafisa Shakir Bata. She is the head of the Sports Imaging Injury Center at the Safdarjung Hospital, which is a tertiary referral center. Her passion is in sports and rehab imaging, and I'm sure she'll add a lot of information to what you already know.
So yeah, I have it on the right and I don't have on the left part.
And I think most of us have it, because these two people are also the tendons differently.
Yeah, so this I have it on this.
Give us something to play with now.
Okay, so good afternoon, everyone. Yeah, I'm sorry, I transported it from Keynote to PPT, and so my font is going to get a bit skewed, but it just says athletic pubalgia, nothing more. And there is no text in this presentation. Now, the idea of this whole presentation is that, you know, you can Google what to report, how to report, classifications, etc. If you can take something away today, take away what is the biomechanics behind the sports groin. Okay, try and understand that. So we know that the abdomen is a layer of 3 muscles, transversus abdominis, and then we have the rectus abdominis with these delightful inscriptions that, you know, most of us don't have. But then there's the internal oblique and the external oblique. Everything is kind of converging, and all the core muscles, when they contract, the forces dissipate at the pubic symphysis. So this is something to understand. And when we're looking at the pubic symphysis, yes, so you can see that this narrow box is an area which is prone to injuries, this area, okay? All right, so now why does this happen? There is a pubic disc, fibrocartilage. So there's a pubic, the pubic symphysis is a fibrocartilaginous disc. On that is the ligaments, the anterior and the posterior ligaments and the capsule. Okay, so that's the pubic symphysis. On top of it, you have a pubic tubercle. On the pubic tubercle attaches your core muscle. No, this one is. Sure. You want to? Why does this generally happen? It's the adapter from a neighboring country. It works and sometimes doesn't work. I don't want to say names. If it was made in India, it would have worked. I have a laptop, another laptop if you want me to use. मेरा laptop है ना? Because if this doesn't work, it won't work for the other speakers as well. Yeah. The entire screen will also work. Okay. No, it must not extend the display, remove it. It won't work here otherwise. Entire screen. Okay, now put it back. Okay. I hope the moderators are considering my time. Yeah. It is a loose connection in your adapter. Karo, karo. It's loose here. Okay, wait. So I can't see the screen. Can you give me a pointer? But we can play it there, okay? Yeah, okay, we have it. So basically, all the core muscles are contracting. Everything comes down to this little space. Now you've seen these matches where there's a player, he goes offsets, the pelvic is tilted, the pelvis is tilted, he drives a forceful kick, and then he falls to the floor. And he clutches his groin, he's in pain. Okay, so this is because the core musculature, okay, is all traversing the forces down to the pubic symphysis and then slightly at an angle to the lower limb. And the same happens on the other side. So you have these force vectors going vertical to slightly at an angle, and you also have force vectors that go cross. So there'll be a force vector from here going into here. This area is continuous. So there's a rectus abdominis, there's a small pyramidalis muscle, there's a prepubic plate or the common aponeurosis. This is the common aponeurosis of the rectus abdominis and the adductor longus, okay? So adductor longus has a fibrocartilaginous disc here which attaches it to the pubic bone, but by and large this is an entire common single unit. There's a lot of ambiguous nomenclature around the sports groin, and there's really nothing that describes it completely. Okay, so a lot of these terms have been used. The most common injury at the sports groin is always an adductor pathology. So here's the entire unit. So there's rectus, that's the anterectus sheath. This is the linea alba, linea seminolaris. That's the inguinal ligament. That's the pubic symphysis. This is the adductor longus going away. Now, when the forces dissipate and there's a forceful kick that is driven here, and if this area is also already degenerated, something is going to tear. And the most common is the adductor longus. But more than tears, you can have tendinopathy, you can have even calcific tendinopathy, you can have partial tears, etc. Now look at this patient. Even if you look at a T1, you see the rectus abdominis, and you can see there's a medial head, medial head, and lateral head. Can you see that there is some amount of atrophy here on the right side? This is a right hand dominant patient. He kicks with the right lower limb. So you can see that, and that itself should point you towards a problem. So even if in X-ray, you can see this unleveling at the pubic symphysis, okay? Okay, so you can see this unleveling at the pubic symphysis, telling us that there is macro instability. There's also an avulsion injury here at the sartorius. This is a 21 footballer. You can see that there is chronic apophysitis at the hamstring region, and this patient has had it for 7 years. He is, even when he was 16, I got a MR for him. And you can again look at this, some amount of sclerosis, some amount of cyst formation, and you can always look at this unleveling. It really helps to know whether there's micro instability or macro. This is macro. Sorry. And here, this is a patient. You can see again, same, this is left-sided changes, more prominent. This patient has left groin pain. This patient also, track and field athlete, has sclerosis bilaterally, but not that much of osseous changes, and there is no unleveling, okay? So that means that there's micro instability, tiny amount of grinding movement causing mucoid degeneration within the pubic symphysis. So here's the pubic symphysis. This is the disc. It gets degenerated. It becomes mucoid-like, okay? And thank you. And then this is the marrow edema in the parasymphyseal plane, is in the bone, is called osteitis pubis. So look for osteitis pubis. And then we also look at something called a cleft sign, but I'll tell you later. Now, you want to look at the bony changes. Is it just sclerosis? Is it osteitis pubis? Along with that, are there microcystic changes? It's going to tell you whether the bone is healthy to start with. Now let's talk about clefts. So now there are two kind of things that happen. We have these high signal intensity clefts. These are, one are actual clefts and the other are delaminations or tears. So we'll start with delaminations. Delaminations are basically tears which are stripping this whole unit, okay? It can be peripubic plate delamination, it can go into the adductor origin, it can go up into the rectus abdominis, linea alba, etc. So these are delamination and they are actual tears. The second thing that happens is that because of mucoid material within this, and there's a capsular tear, there's going to be leak of this mucoid material into this region, either superiorly or inferiorly, in which case these are basically just fluid clefts. They don't cause a weakness, but yes, you could have long-term injury in this patient. So here's a cleft. Can you see that? It actually communicates with the mucoid material and the fluid in the pubic symphysis. So whatever is in the pubic symphysis is actually a primary cleft, and whatever is going outside, and usually it goes inferiorly and posteriorly, is a secondary cleft. And this is a delamination. So this is an actual tear of the common tendon. There's a delamination. But if you see, this whole unit is okay. In this patient, you see osteitis pubis, and you start to see at the adductor footprint, you see some signals here. All right, this is how we have adductor tendinopathy. And here, so this is a triangle of the adductor longus. It's not in the midline, it's just para-midline. And this is a normal attachment. All right, so this is the triangle you're looking at. And then when you go to the other side in this patient, first of all, there's a tiny delamination here. And when you go to the other side, you start to see that there is an actual interstitial footprint tear. The entire adductor is not avulsed. There is osteitis pubis, and there's an interstitial footprint tear in this patient. Very well seen on these. Now, what are these images? Basically, the pubic symphysis is here. If you cut across perpendicularly, you get what is an axial oblique image. And this image gives you a lot of real estate at the pubic symphysis. In the coronal oblique, we are going parallel to the pubic symphysis, and so you get this kind of an image. So basically, you get, again, a lot of real estate. You can see that secondary cleft so well seen. And you won't get this kind of image unless you acquire axial sections. So here's a patient. He has groin pain, and you look at these adductors coming off. There is tendinosis here as well, but now because of this tendinosis, there is a tear of this adductor. You want to tell the surgeon how far it's retracted. Here's that area. That's the delamination into the prepubic plate, and that is the tear within the adductor. Okay, so oblique images, axial oblique images, you can see that this is a tear of the adductor longus tendon. That's the tendon normal, that's the tendon torn. Go down and you start to see the retracted tendon here. To start with, you can see that the rectus abdominis in this patient were asymmetrical, isn't it? So that means that there was less force going through the right system. To start with, there's probably a previous tear of the rectus. And so now this patient has landed up with an adductor longus tear. Here's a tear where this is retraction can be sizably measured. And if the surgeon wants to go in and anchor it, they can. You can see the asymmetry in the rectus, meaning something is going to happen a little below the pubic symphysis. You can also see an inguinal hernia. Now, in this patient, there's a sports hernia. And that's because there's a tear of the inguinal ligament. Okay, so there's a fatty hernia here. But at the same time, you see there's asymmetry. That's the hernia. And something is happening at the pubic symphysis. The high signals. There's a huge rip-off here. The entire adductor is out. There's a bit of retraction. And if you look at the sagittal, it's not just the adductor. The delamination goes all the way and also tears the inguinal ligament. So you see all this? The entire unit. So the rectus abdominis is completely detached from this unit. Okay. So here's a footballer. Again, you have a tear of the pectineus as well. You can have tears of the adductor longus a little into the thigh, so mid-adductor longus region, myotendinous junctions as well. And okay, here's a patient. If you see this patient, there's again asymmetry. In this patient, there's no rectus attaching to the pubic symphysis, just a linear scar. So this is an old rectus avulsion, completely avulsed. And now he came to us after 6 years. There's nothing really that can be done. There was a big gap here of 2 centimeters. You can't really repair something like that. He's a cricketer, only 19 years old, but really not much can be done for patients like these if they report to you this late. Okay, so here's the normal side. And so structured reporting, look at the osseous changes, look at the aponeurotic prepubic plate, take a picture if you need to. Adductor longus injuries are most common, strain, tear, tendinosis. Rectus abdominis, symmetry, strain, tear, tendinosis. See if the clefts or the tears are going into these structures. And also you can have other associated pathologies that can mimic a sports groin. So if you have a negative examination for the sports groin, it's good to go and see if there are any other pathologies. Okay, thank you.
Thank you so much, ma'am, for such a detailed and wonderful lecture. Anyone having any questions? Thank you, ma'am. So it is my immense pleasure to welcome our next speaker, who doesn't need any kind of an introduction, and bas naam hi kafi hai, Dr. Malini Lavande, ma'am. She's a chief consultant MHK radiologist at Innovision Imaging and Nanavati Max Super Speciality Hospital. She's a recipient of 15 gold medals in MBBS, and there are other multiple medals in her entire career. And she's one of the great teachers for many students.
Good afternoon, everyone. Thank you so much for the opportunity to be here and in this wonderful city of Ahmedabad. And it's really nice to see such a full crowd in the post-lunch session. It doesn't happen usually. Believe me, I've taken a lot of post-lunch sessions. It's never this full. So you've been a wonderful group of interested delegates. And it's so nice to see friends and all students who have become friends in this crowd here. So let's start looking at BAMIC classification and why is it needed and how do we grade it. So it looks very complicated, but I'll try to make it very simple. So why do we need it and how exactly when we look at a case do we say what BAMIC grade is this injury? So now whether it is the greatest of all time, Messi, or his biggest fan, that's my son. This is few years back, he's older now. But when they get injured, both of them have the same question. When can I get back to play? And that's exactly what BAMIC tries to tell you. Because when there is injury, and especially nowadays, there is a lot of money involved, especially the important players, when will they get back to play? It has got like really lot of consequences, implications with respect to the player, with respect to the team, the finances. There's a lot riding on it. And clinical examination is not enough because the hematoma is filling up the defect in the muscle. Synergists are recruited. We know that the function itself testing is not always reliable. Tears can be deep and not exactly palpable. Also spasm, pain, guarding makes it very difficult for the physiotherapists, for the orthopedicians to try to judge the degree. And all these years we've been using this simple grading that we have been using. Grade 1 is where, I think, can we have this light off? It would be better for everyone to see. Yeah, no, I think this light. There's something wrong. Oh yeah, okay. Connector, there's a problem. Oh yeah, then the muscle edema, everything will be seen as edema. Oh yeah, I didn't notice that. Oh, I'm not being artistic. Here it's nice and shiny. क्या कर रहे हैं? ब्लड नहीं, उसके अंदर ऐसा कुछ कलर शेड, वो डिजिटल पिक्सल जैसा उसमें भी है, वो सब में है. Only the theory. After this, it's all images only. So, you just can't see anything. It's all pixel kind. My laptop, I didn't even bring it.
Switch कर दे बाबू, switch कर. पहला बढ़िया, पहला सारा जैसे.
जब उनका लगा दीजिए, उनका नेक्स्ट है, उसमें होता है कुछ. पेन ड्राइव से चला दीजिए.
I'd like to just add a bit about the side streams and the numbers from neck injuries that we talked about earlier. And when you have a young patient who's a sportsman,
and if they come to you for an MRI lumbosacral spine and you say, oh good, I got a young patient, nothing, vertebral normal disc now will be. Look at the bars. This is when, before you feel happy, look at the bars, okay? Because a young patient, why would a 17-year-old land up doing a lumbosacral spine? Now, apart from cricketers, also weightlifters, powerlifters, gym injuries, these are the problems that we face, okay? So, if you have a patient who's a long jump, track and field athlete, high jump, gymming recently, pars fractures do occur in these patients. We've had power lifters who had bilateral pars interarticularis injuries, mix of acute and chronic at L5, at L4, and now developing at L3 as well. So be very careful when you have a young patient, and this gym activity is something that you need to ask them in retrospect if you get a normal scan. The second thing is that side strain. While everything you can see well on an MR, if you can't find any pathology, but the patient comes with this rib pain, This is because of the way the core muscles are arranged, and there's traction at the ribs causing chronic periostitis. And in such a patient, always go and ask for a CT, and you'll see that chronic periostitis when nothing else is seen, and it's a painful process. Okay?
Yeah. So now that it's visible well. So all these years, we've been using this very simple grading. Grade once, and we use the term strain initially. So grade 1 strain, there is just edema, feathery edema, and we give the size of it. Grade 2 strain, when there is partial disruption of the fibers, there's some hemorrhage, there is some fluid collection within the muscle. And grade 3 is when there is a full thickness tear of either the muscle or the myotendinous junction. But the problem with this is it oversimplifies everything. It just gives you the grade. It doesn't tell you the location where the tear is happening. It does not tell you how much of the cross-sectional area of the muscle is involved. So this does not really correlate well with prognosis and the time for return to play, the risk of re-injury. So that, that it was not collaborating with it. So then this is not useful. So then how exactly do we look at tendon pathologies? Because if you look at a tendon tear, a free tendon tear, recovery of that is different from a pathology or an injury at the myofascial junction. Myofascial injuries recovery is faster as compared to when there is tendon involvement. So keeping all this in mind, what they decided was for prognosis and management, it's not only the extent, you want to know the severity, you want to know the location. The location also is equally important. Whether it is the myotendinous junction, it's the attachment, is it the myofascial, all of that. So multiple staging systems were thought of. Munich muscle injury classification was quite popular. You have in that a functional and a structural grading and then further grading. Chan et al. Came up with a different system of grading. And then the BAMIC grading, which is British Athletics Muscle Injury Classification. This was described by the British group who are primarily treating the track and field athletes. And later it has been applied and studied in football players. In our practice, we personally see this more in football players and cricket players too. It was initially described for hamstring injuries, but now it has been applied to the other muscles also, and it does correlate well with return to play as well as the risk of re-injury. So let's look at what exactly is this. Ideally, the scan has to be done within the first 48 hours of injury. Placing a pain marker is really important because especially when the patient is injured during the play, you'll have so many areas of edema which are nothing but just activity related edema. Or if it was a day or two, it could be DOMS, delayed onset muscle soreness, you have edema. So every edema is not the cause of symptom. So placing a pain marker, we use a vitamin E capsule, is really important. So you know you are looking at that area, and also you make sure that it is covered in your axial sections well. Stir or T2 fat sat in all 3 planes, and axial and sagittal T1 or PD. Any of these can work, but you need stir in all 3 planes is what is recommended in the original article. Now, if we look at BAMIC, you have 2 different gradings. One is the grade, which goes from 0 all the way up to 4. Obviously, the severity goes on increasing as it goes in this direction. And you also give a suffix to it. The suffix can be A, the suffix can be B or C. This also again increases in severity in the sense the return to play is going to get worse as you go down from A to C. A is myofascial. B is myotendinous junction. And by myotendinous junction, we don't only mean where the tendon, the free tendon and the muscle is starting. It's the intramuscular tendon. Hamstrings and all of you see it's a very long muscle. You have a long intramuscular tendon itself. So it's that area. And C is intratendinous, the tendon itself. Okay, that's how we grade. So there'll be a number grade and there'll be an alphabet attached to it. So grade 0 is, A is negative MRI. Patient has an injury. There's a focal area where there is pain, but the MRI does not show anything. So these patients obviously have the best prognosis and are going to get back to play very quickly. And most of these patients, the player completes the match and then later comes with, there is pain which is there. B is more generalized muscle soreness. MR may be normal, or MR can just show diffuse edema in the muscle, which is the delayed onset muscle soreness. We all know that when we suddenly go trekking, we suddenly play cricket or something, after many days, 2 days, our body starts aching. That is DOMS. We don't do MR for this most of the times, because especially in players, this is a very well-known kind of phenomenon. Grade 1, remember it's only A and it is B. I'll show you all the images, but first let's just understand. There is no C, because an intratendinous injury has a longer time to return to play. It's a more severe injury. So there is no grade 1C at all. There is only grade 1A and B. In 1, what do you have? If there is edema, you look at the location. Is it at the myofascial, near the myofascial area, or is it at the myotendinous junction? Accordingly, it will be A or B. It involves less than 10% of the cross-sectional area. If you measure the craniocaudal length of the edema, and we are measuring the edema in the muscle, we are not looking at the intermuscular plane fluid, we are not really measuring that. Craniocaudal length will be less than 5 centimeter. Fibers could be disrupted, but only less than 1 centimeter. So less than 10% cross-sectional area, less than 5 centimeter in length, and less than 1 centimeter fiber disruption. When we move to grade 2, now you can have A, B and C, all three. 10 to 50% of cross-sectional area of the muscle edema. Obviously look for axial images in this. Craniocaudal length of 5 to 15 centimeter, measure it on corneal images or sagittal images. Fibers, if disrupted, are less than 5 centimeter. And the tendon can be involved. So there is a 2C. The tendon cross-section area which is injured will be less than 50% of the tendon diameter. You move to 3, more than 50% of the cross-sectional area, length more than 15 centimeter, fiber disruption more than 5 centimeter, more than 50% tendon cross-sectional area involved, and you could just have wavy appearance of the tendon on the corneal images. So it's very important to look at the corneal images. You need large field of view images, and you'll see that the tendon has lost its taut appearance and it has got a wavy appearance. And grade 4, when there is a full thickness tear of the muscle or the tendon. Now, free tendon tear, we do not grade as BAMIC, one at the origin. For example, a hamstring origin tear from the ischial tuberosity itself, you give the thickness of it, you give the retraction, you don't give BAMIC grading to that. It's myotendinous junction, and in the muscle is where you do this grading. So this is a full thickness tear from the origin, retraction this much. I'll not really grade it BAMIC. Let's start looking at examples. There's edema. Where is this edema centered? At the myofascial area. So this is where the fascia is there, and you have this edema. It's involving less than 10%. The length is less than 5 centimeter. This is 1A. Here, if I look at it, where is the location? So the intramuscular tendons are usually in the central portion, but as the muscle goes down, each muscle has a different location of the intramuscular tendon. So here you have edema just around the intramuscular tendon in the long head of biceps femoris. The length is more than 5 centimeter. Cross-sectional area is not much. So go by whatever is goes to the higher grade. So if you have something involving less than 10% of the cross-sectional area, but the measurement is coming to 8 centimeter, still give it grade 2, give the higher grade. Now here what do I see? I see edema right along the myofascial, in the muscle, and this is the, now here this is the tendon. You have the indirect tendon of the rectus femoris, and you can see there is edema around it, and there is some fiber disruption. You can see this fiber disruption here, and that length, overall the length was more than 5 centimeter, the fiber disruption was more, this is 2B. So this is tendon. If I look at it here, again another example, this is the intramuscular tendon, you can see here. So it is centered around it, kind of try to see the epicenter of it. It's over a long distance, and if you notice here, you can see a disruption of the tendon itself. So this becomes 2B. While here, if I look, this is centered more towards the myofascial junction. I'll just quickly finish in the next few slides. Myofascial junction, and you can see fibers are disrupted much more. So this is 3A. And here you can see the tendon still looks taut, it's a longer distance if you measure, and the fiber disruption is more than 5 centimeter. That becomes 3B. And in this case, you can see the tendon here has lost its taut appearance. It has got a wavy appearance. I couldn't exactly, in one section you may not see it, you may have to trace. If you feel the tendon wavy, that makes it 3C. And this is 4, where you have a clear disruption all through the muscle, or you can have a full thickness disruption through the tendon, which makes it 4C. So you just have 4, which is muscle, and 4C, which is tendinous. This is also a 4C, where you can see there is a clear defect, full thickness defect in the tendon. And this are example. This is initial scan, and here you can see it has resolved. This is the initial scan, and you can see it has resolved with scarring. You can see the scar here, scar tissue, but now the patient has come with another injury. Can we predict return to play? So more than 50% muscle area involvement, intramuscular hemorrhage, distal myotendinous junction injuries, ganglion-like fluid collection in the muscle, all of them have a longer return to play. Normal MRI means the return to play is going to be really quick. I'll just skip the, a lot of studies have been done, and what they say that amongst all the grading systems that have been used, BAMIC is the one that has most correlated well with return to play. Grade 1 injuries, about less than 2 weeks, 2 weeks or so, then 3 weeks to 8 weeks, 3 to 6 weeks, and the higher grade ones would be almost 8 weeks to 3 months return to play. So it has correlated the best. It's not perfect method, but amongst all that are currently available, this is the one that has most corroborated well with return to play as well as risk of injury. Again, I'm sure you don't need to click picture of this. It's available on Google. Just understand what does it tell you. The grading increases 1, 2, 3, 4, and there is always a suffix A or B or C. It allows us to have a common language that the treating physiotherapist, the orthopedician, the sports medicine person, we all talk the same language. When I say BAMIC this grade, it's the same language that we all are speaking. Thank you.
Thank you, Malini, for an excellent job. More importantly, for making us understand the language and also that we should communicate in the same language as the sports and youth section. The next speaker is Dr. Gaurav Bhatte. He is our young gun of MSK Radiology, the man, as we say, with the longest arms and the best selfie. His areas of interest include rheumatology, pediatric and imaging. Over to Gaurav for the
Hi, good evening everyone, and thank you for joining us in the post-lunch session. I will be speaking on meniscal ramp lesions. This is one very dear topic to my heart, which I have also learned over a period of time, and I would like to share my experience with how I see meniscal ramp injuries. Okay, so the first most important is, what is a meniscal ramp lesion? So any longitudinal or oblique tear in the peripheral zone of the posterior horn of medial meniscus. So just remember, it's a posterior horn of medial meniscus with a longitudinal peripheral tear or an oblique peripheral tear in the red zone area at the meniscocapsular junction. Okay, so it is associated with ACL injuries in approximately 15 to 40% cases, and it is recognized as a key driver of knee stability. Whenever there is a ramp lesion, and if not corrected, can lead to persistent knee instability and patient leading to osteoarthrosis. Hence, the posteromedial corner, the posteromedial junction requires a great scrutiny while you are evaluating your ACL injuries. So a peripheral longitudinal or oblique tear, as I discussed, is one of the most common area in the ramp region. Along with that is the meniscocapsular separation. And the third thing which we need to look at is the meniscotibial ligament. So loss of primary knee stability in the presence of ACL deficiency is attributed due to the ramp lesions. So let's come to the anatomy. So this is the medial meniscus and this is the posterior horn. So the posterior horn is stabilized by a capsule which forms the meniscocapsular junction. Okay, so it's a very easy way to see it. So as we look at this diagram, so this is the posterior horn of medial meniscus and the red color demarcates the junction between the capsule and the posterior horn. So this helps to restrain, it helps to stabilize the joint, it helps to reduce the load on the ACL whenever there is active movement while sports events. So whenever there is a footballer who is just running hereby with his ball, so there is a rotatory activity as well as the anterior movement of the two bones, the femur and the tibia. So this helps to give extra support to the ACL and preserve the knee joint. So this is a diagrammatic representation of the posterior horn. So as you come, this is the posterior horn of medial meniscus. The peripheral area, as I said, the red zone is rich with vascularity, and this capsular attachment is the meniscocapsular ligament. As you come on the lower side, this is the meniscotibial ligament which is attaching to the tibia. So this forms the ramp region, not the lesion. Okay, so this is the normal appearance on MRI where we can see the jet black posterior horn of medial meniscus, while the meniscocapsular ligament strengthens it on the undersurface of the femoral condyle, while the meniscotibial ligament attaches to the tibial side. So dynamic complex securely anchors the posterior medial meniscus to the posterior tibial rim, and this ensures load absorption during the flexion. So whenever there is an injury to the ACL, there is active flexion which happens in the knee and the load increases on the posteromedial surface of the knee joint. So the biomechanical role is that it acts as a critical secondary restraint in anterior translation as well as the rotation. So whenever there is a sporting injury happening, the posterior medial fibers, the capsule, this will help to restrain, this will help to protect the joint as well as the ACL. Similarly, in post-surgical cases, whenever there is an ACL reconstruction which has happened, if this area is not repaired well, what will happen is that there will be more strain over the repaired graft, which will essentially lead to elongation, more stress over the repaired graft, and hence graft failure. Various anatomical risk factors are associated with ramp lesions. One is the increased medial tibial slope, varus knee alignment, concomitant deep fiber MCL tear, and delayed ACL reconstruction. So let's just look at what is the mechanism of injury. Whenever there is an ACL tear, there is anterior translation of tibia over the femur. There is translational bone marrow edema, which we can appreciate here in the form of the kissing contusions in the anterolateral femoral condyle and posterolateral plateau. Along with that, whenever there is injury, there is flexion in the knee and there is increased force on the posteromedial complex at the meniscocapsular junction, which will lead to shearing injury. And when unnoticed and it goes on, it leads to microinstability and hence chronic laxity. So why ramp lesions are easily missed by our radiology and orthopedic colleagues? One, because this area is the most posterior part of the medial meniscus and is an arthroscopic blind spot. So primarily when they go in for a scopy, they go via the anterior portal, and through the anterior portal they cannot see the posterior most part of the medial meniscus. So that is very important for us as radiologists to mention if there is any concern in that area, so that the arthroscopic surgeon is well prepared that he has to look into that zone. Second is a knee MRI extended position. Because of the extension, it compresses the posteromedial capsule and hence subtle tears can be missed. And thirdly is your eyes see what your mind knows. So awareness of this topic, that the ramp lesion is a very essential area to look at whenever we are evaluating our knee MRIs. So the primary criteria is a discrete fluid cleft longitudinal to a greater length or a smaller extent, a sagittal fluid filled gap, which we can appreciate in the arrows annotated here in the posterior meniscocapsular junction, and any irregularity along the surface of the medial meniscocapsular junction, and there may be associated small oblique or horizontal tears along with that. The indirect signs will be kissing contusions or bone marrow translational edema in the posteromedial tibial plateau. There may be deep fiber medial collateral ligament injury associated, and any fluid signal along the body or posterior horn of medial meniscus in the adjoining synovial recesses. So there's one classification, the Thornett arthroscopic classification. We do not use it in our reporting about 1, 2A, 2B, 2C, but it is just to understand of what we are correlating with. So the idea of looking at these ramp lesions to understand this is that when we are going out of this room and giving our reporting on ACL tears, we have to look at these areas. We need to inform the surgeon that there is a concern for a ramp lesion, so that they can just go and look from the posteromedial approach as well. So type A is a meniscocapsular lesion which is at the synovial junction. So it is only the meniscocapsular junction injury. In type 2 ramp, it's the red zone involvement. So it is an incomplete or a partial tear at the meniscocapsular junction, but primarily in the posterior horn of medial meniscus. Then ramp type 3 is divided into A and B, where the inferior part of the medial meniscus is involved, which is reaching till the articular surface. The type 3B involves the inferior articular surface, again an incomplete tear, but also involving the meniscotibial ligament. Type 4A involves a peripheral longitudinal tear in its entire extent. It's a long segment tear, while 4B is a shearing or a stripping injury at the junction. Type 5 ramp lesion is a double vertical longitudinal tear. So all these things, there will be various spectrums, there will be overlap in the meniscal injuries. So it's never type 1, 2, 3, 4 or 5. Okay, so let's go with some examples. So the most common appearance when we look at the ramp lesions in an ACL injury, as we can see in this image, that there's a full thickness tear of the ACL. Okay, this is the proton density non-fat site. Here we can see there are no healthy fibers in the site of expected ACL ligament. And here we see that there is peripheral longitudinal tear at the meniscocapsular junction. It's involving complete junction involvement. Okay, so it's a type 4 ramp lesion, but we really don't mention in our reports that it's type 4. It's just for the correlation with the classification that is mentioned. There's another area where we can see that there is tear here at the meniscocapsular junction marked with the arrow, and we see two longitudinal tears in the posterior horn. So it's a double longitudinal tear, supposedly ramp type 5. And on the axial images, we can also see that this corresponds to the posterior medial meniscocapsular junction injury. Next is a case with ACL tear, and we can see a small anterior intercondylar notch nodule. There is irregularity along the meniscocapsular junction, and there's a thin oblique tear in the residual posterior horn as well. And if we see the third image, the coronal fat sat images, we can see that there is deep fiber medial collateral ligament injury. Next is again an ACL injury. We do not see any ACL ligament on the SAG images here. Okay, and here we see a complete stripping injury at the meniscocapsular junction with a posteromedial tibial bruise. Apart from that, if there's a medial meniscus tear, the lateral meniscus can also have a brunt. And here we can see a longitudinal tear at the site of Risberg ligament attachment to the posterior horn, and it is extending till the body junction, which is a Risberg rip. So whenever the surgeon is going for a scopy, he has to then operate on both the ends. Next is again an oblique longitudinal tear in the posterior horn of medial meniscus. Okay, there is injury to the meniscotibial ligament, here we can see, and this is the fluid cleft, which is perfectly seen. So these are the areas which we need to look at very carefully. Okay, so this is a case again where we can see a small flap coming up, so a probable bucket handle tear which was happening and going into the intercondylar notch. And here we could see an incomplete tear at the meniscocapsular junction, supposedly type 3B from the Thenard's classification. This was type 1, only a low-grade injury at the meniscocapsular junction. So at least if you see an edema there, just write it down in the report so that any which ways, if there's an ACL injury, they are going for a scopy, they might just explore that area. Okay, and this was again case of a ramp tear. Here we can see the ramp lesion, the longitudinal tear, and here we can see that there is injury to the conjoint tendon of biceps femoris and fibular collateral ligament. So as we come from top to bottom, we can see the fibular collateral ligament here, and sorry, one second, just last few slides. So this is the fibular collateral ligament coming and going towards the biceps femoris where we lose it, and that's the posterolateral corner injury. Okay, so what is the role of a radiologist in identifying these lesions is to alert the surgical team, because without MRI suspicion, the surgeon will probably miss these. Why this is important? Because once he is going in for the surgery, he knows where to create the portal. So it's a supramedial portal, an anteromedial portal, a posteromedial portal, and a trans-notch view. So a trans-notch approach is that he will put in the probe through the intercondylar notch and reach the posterior part, and he will use his hook to look at where is the tear, and then through the posteromedial, from another area of the portal, he can go and repair it. So surgical management depends on what we give in our reports. As a radiologist, we can discuss, and the exploration, debridement, suture repair, and rehab protocol all depends on that. So this was freshening of the ramp tear, which was viewing from the anterior portal, but the surgeon was operating from the posteromedial portal. Okay, so he just freshened, cleaved the edges, and the final repair was done with the all inside suture, and then he's checking with the hook that the stability has been maintained or not. So ramp tears are very essential to know. Every one of you who is here, whenever you read your scans, at least look at this area before you sign off. Thank you very much. And how we as radiologists can create an impact on patients' outcome is that by giving them a targeted surgical exploration assessment, protect the ACL graft integrity, and saving them from developing young arthritis. Thank you very much for your attention.
Yeah, thank you, Gaurav, for a wonderful talk. Last Dr. Nafisa to add a few points, please.
I think this was an excellent presentation, Dr. Gaurav. Thank you very much. What he mentioned here is that they do a hook test. At times we report a ramp tear and the patient gets an ACL reconstruction, and maybe the surgeon goes in after 3 months, 4 months. Sometimes a ramp tear, because it's so peripheral, can scar and heal. And so the surgeon might come back to you saying, oh, you made a unstable ramp tear. But sometimes when they probe, it will break. The scar tissue will be so fragile. Otherwise, at times the scar is robust. Just remember that type 3 onwards ramp lesions are unstable. 1 and 2, if you want to mention, it would be okay. Yeah.
So our next speaker is Dr. Vijay Papineni. He is a lead consultant MSK radiologist at Sheikh Shikhawout Medical City, Abu Dhabi, UAE. He is a current vice president of Emirates MSK Radiology Club. He is a recipient of multiple medals and awards internationally. Over to you, sir.
Thank you for the kind introduction, and thank you for the opportunity. Mine is a simple topic of extensor mechanism, imaging of the extensor. That's where I work in Abu Dhabi. So we're going to go through the imaging patterns of quadriceps tendon first, then patellar tendon, and look at some patterns in the patella itself. Not going to go through mal tracking because that itself is a huge topic. So a normal quadriceps tendon, as you can see here, it has 3 layers. The most superficial is the rectus femoris. The middle layer consists of vastus medialis and lateralis, which is the middle thick one, and the deepest is the vastus intermedius. So and then the rectus femoris has a continuation. It's called prepatellar quadriceps continuation, which is it has a fibro-osseous cartilaginous connection with the anterior aspect of the patella, and it continues as a patellar tendon. So although there are 3 different structures, they are together. Like Nafisa showed that the the abdominal muscles and the adductors continue in front of the pubis. So it's kind of, you can think in the similar manner. So one thing you have to keep in mind is the magic angle that that can happen in the extensor tendons, especially patellar tendon, where you can misinterpret the magic angle for tendinopathy. So be aware of that. It's very common in patellar tendon, especially when it is at an angle to the magnetic field. So proton density images are more prone to it, so always check on the T2 images. Coming to the quadriceps tears, it's the commonest area it would tear is at the attachment of the patella, where it directly attaches, and the different layers can tear at different levels. For example, in this diagram, you can see that it is torn here, or the middle layer can turn higher up. So always look at different planes, and this is an example of a tear at the level of the patella, and there is a significant retraction. The deepest layer, which is the vastus intermedius, is the least common to tear. So as you can see here, this is the involvement of the top two layers are involved, rectus femoris and medialis and lateralis, but the intermedius is intact. Whenever you're looking at a quadriceps tear, always check the X-ray or a CT scan if you have. Sometimes there may be a small avulsion bone fragment which may not be easily seen on a MRI scan. So a tiny avulsion bone fragment, as you can see here in this plain X-ray, is only seen can only be seen on the plain film in this case. This is another example, abnormal looking patellar quadriceps tendon which is torn at this level, and there is a partial tear of the patellar tendon as well, and this patient had a repair done, and this is 8 months post repair. So they can be both patellar tendon and quadriceps tendon tear at the same time, depending upon the type of the injury. This is an example of isolated tear of the vastus intermedius, the deepest layer, which is not that common, but it can happen. But other thing is, as I told you, always check all the other planes as well. And in this one, there is a muscular tear of the vastus medialis here. So this may not be appreciated if you don't look on the other planes as well. Again, as we always teach, always look at the edge of the film. This patient had previous surgery. He has got a tear at the more proximally within the quadriceps tendon, and you can see that tendon is quite abnormal. Always look at the edge of the film. Again, to stress the same point, always look on the other planes. In this, you can see that the vastus lateralis is intact, but the medialis is torn on the axial plane. And if you look on the same patient, if you look on the coronals, you can see that there is a rectus femoris tear as well. So always check all the planes before giving your report. This is an example of tendinopathy with intrasubstance delamination, and the middle layer is partially torn and slightly retracted, and you can see a bit of osteitis as well with bone marrow edema. This is a graft site complication. Patient had a ACL graft. Donor site was donor from the quadriceps tendon, and you can see that there is extensive bone marrow edema after the surgery, and patient develops septic arthritis and osteomyelitis. So this is a quadriceps tendon graft complication. Sometimes you might get incidentally a hematoma or even a tumor. This is an example of a chondroma of the quadriceps tendon, which is quite rare. And this is courtesy Dr. Bochu. This is a tumor of the quadriceps tendon. Coming to the patellar tendon pathologies, this is a example of a Jemper's knee where there is significant thickening and edema of the proximal patellar tendon with interstitial tears. And in this example, you can see the cystic change at the attachment at the lower pole of the patella. So this is a chronic, this is a more acute one, and this is a chronic one where they develop bit of changes, bony changes within the distal pole of the patella. Again, another example of proximal patellar tendinopathy where there is intrasubstance central tear, which is asymptomatic. Patient doesn't have much symptoms, but patient has intrasubstance tear. Again, reiterating the previous point that again this patient has significant patellar tendinopathy, and if you see the fascicles, different fascicles are torn at different levels, and unless you see it on the coronal scan, the most anterior images, you may not appreciate the extent of the injury. So always look up on different planes. Again, this is a slender Larsen-Jones syndrome. This is a overuse of the extensor mechanism injury, where there is apophysitis and extensive bone marrow edema at the site of the apophysis, and there is edema within the anterior fat pad. And coming to the distal patellar tendon, Osgood-Schatter's disease is an insertional tendinopathy at the level of the distal insertion, with there is apophysitis of the at the attachment site to the tibial tubercle. They can be it is common in overuse athletes. Just last few slides. So there is avulsion or sometimes fragmentation of the epiphysis, and there can be associated patellar maltracking or patellofemoral chondropathy as well. This is a more chronic case where there is patient had Osgood-Schatter's disease as an adolescent, and he has been having recurrent problems. You can see this fragmentation of the tibial tuberosity, and there is chronic tendinopathy, shortening of the tendon, and retropatellar bursitis as well. This is an example of a patient with distal patellar tendinopathy, which in time became cystic change within the patellar tendon, and you can see this mucoid degeneration of the patellar tendon. This is a chronic tear of the patellar tendon, where you can see that it has been long-standing. There is no edema. There's a bit of fibrosis in the fat pad here, and there is significant retraction as well. This is again donor site complication of the bone patellar tendon graft, where there is persistent edema at the site of the defect within the patella, and you can see there is tendinopathic changes throughout the patella. This is a incidental osteomyelitis of the proximal tibia and involving the distal patellar tendon. So this is infection involving the patellar tendon. This is an example of synovial sarcoma, again courtesy Dr. Bochu. So synovial sarcomas can involve the extensor mechanism. This is distal patellar tendon infiltrating soft tissue tumor involving the distal patellar tendon. This is again incidental finding with a lucent lesion in the tibial tuberosity, and this was biopsied. It was thought to be a cartilaginous tumor preoperatively, and patient had a surgical biopsy, and it turned out to be a benign cartilaginous tumor. So one important aspect that people but yeah, there's last slide, last two slides. This is prepatellar quadriceps continuation injury. So as I told you, the superficial fibers of the quadriceps continue on the anterior aspect of the patella, and you can get injury at this level. I'll show you a couple of examples. This is a patient who had a fall, and you can see that this discontinue of the prepatellar continuation of the quadriceps. There's a lot of edema, and this is a lesser severe example in a another athlete with edema of the prepatellar continuation. This is a chronic example. Patient does not have any tendinopathy, but you can see there is previous injury to the prepatellar continuation with traction spurs. This is a patellar sleeve injury, and I will not go through all the. Let's go to my last slide.
Thank you, sir.
Thank you.
Thank you. Thank you for an excellent talk. I think it deserves a big round of applause. Thank you.
Thank you.
I'd like to call upon the next speaker, Dr. Khamis. He's attached to the Khawla Hospital at Muscat in the Sultanate of Oman. He's a senior consultant out there. He's got 20 plus years of clinical teaching and research experience, and I'd hand over the mic to him for the next talk, please.
Thank you for your kind
I just request Dr. Khamis to stick to the time, please. Thank you so much.
Thank you for a kind introduction. In this short presentation, I will be reviewing the ultrasound and MRI imaging finding, highlighting the imaging feature that help in diagnosis and guide management for the tennis leg. The outline of my presentation include brief introduction, overview and anatomy, pathophysiology and clinical presentation, ultrasound and MRI finding, and finally, few take-home messages. So the tennis leg is one of the most common acute calf muscle injury encountered in the sport medicine. It was first described by the Powell in 1883, long time ago, and initially attributed to result from the plantar tendon rupture. However, current evidence show that most cases involve a tear of medial gastrocnemius at the myotendon junction, while less commonly the soleus or plantaris may also be involved. Classically described in tennis player, but also encounter occurring in other sport activities, including running and skiing. This is one of our elite tennis player. Let us recap the anatomy of the calf muscle. The superficial calf muscle include the triceps surae, which is consists of gastrocnemius, which has medial and lateral head and soleus. Both muscles make distally to form the Achilles tendon that inserted in the posterior calcaneus. Gastrocnemius cross both knee and ankle joint, whereas soleus cross only the ankle. Primary function of both muscles are flexion of the ankle, but gastrocnemius also assists in the knee flexion. Here we have the MRI image, normal anatomy. We can see the posterior image that medial and lateral head, and more anterior deeply the soleus muscle. In the axial image, we can see the medial head of the gastrocnemius is larger than actually than the lateral, and deep to it the large, broader soleus muscle, and in between them the plantaris tendon. Plantaris tendon muscle, it is a small muscle that have thin, with long tendon running between the medial gastrocnemius and soleus. Is absent in approximately 7 to 20% in normal population. Gastrocnemius and soleus are pinnate muscle. That means the fiber run obliquely to insert into the broad aponeurosis, forming a long myotendon junction, as we can see in the ultrasound. Normal ultrasound anatomy, we have the subcutaneous fat, we have the medial gastrocnemius, soleus, superficial aponeurosis, deep aponeurosis, and then the free gastrocnemius aponeurosis that is continuous to contribute to the Achilles tendon. The pathophysiology and clinical presentation, typically the mechanism force ankle dorsiflexion with knee in extension that lead to eccentric contraction of the gastrocnemius, which lead to tear at the myotendon junction, which is the weakest point, and is typically also seen in middle-aged patient. Patient or player experience a sudden, sharp posterior calf pain, often with a pop or snapping sensation, local tenderness and swelling. Occasionally, a palpable defect may be present in case of severe injury. Imaging of the calf muscle injury, ultrasound is the first line imaging modality for suspecting middle gastrocnemius injury, confirming the diagnosis and differentiate from other diseases like rupture of the Achilles tendon, rupture of the Baker cyst, which can present with the same, or deep vein thrombosis. It localizes the injury, and dynamic ultrasound also help in evaluation the muscle aponeurosis integrity and gastrocnemius soleus sliding. Here we have an example of image of ultrasound from patient who has calf muscle injury. You can see there is increased echogenicity of the gastrocnemius fibers consisting with acute muscle injury. When we scan down inferiorly to the myotendon junction, we can see there is a fluid around the myotendon junction and associated with disruption of the muscle fibers. Here another extensive tear that is causing large partial tear extending to the myotendon junction and also extending to the free aponeurosis of the muscle. Here is another example of large tear at the myotendon junction filled with the gap filled with the hematoma. Ultrasound also can diagnose the plantar tendon injury. In this case, we can see the thickening of the plantar tendon with increased echogenicity consisting with acute injury. MRI is a gold standard for comprehensive assessment of the calf muscle. It precisely localizes the injury, define the extent, and also useful when the ultrasound findings are equivocal or symptoms persist. Here typical MRI findings, we'll see the fluid between the medial gastrocnemius and soleus, and when traced down to the myotendon junction, we can also see the involvement of the myotendon junction, which is typical site of injury. Here we have the plantaris, which is intact. Here another patient with diffuse muscle edema, fluid in the deep fascia and superficial. And here the fluid is tracking along the tear involving the myotendon junction and also the disturbances involving the muscle fibers. Here another large extensive muscles injury. There are a lot of internationally recognized classification for muscle injury. It has strength and weakness. The purpose is to provide a standardized description of muscle injury and also provide prognostic information for the treating team. One of the most common that covered by Dr. Malani is the British athletic muscle injury. I'll not go through it. And we can see here we have the type 1B that involving myotendon junction. And then we have a more extensive tear around the myotendon junction is the 2B, and here we have the extensive muscle tear involving the tendon, and also there is the tear of the plantaris. And this is the grade 3C, which is carry the worst prognosis. Take home message: tennis most commonly results from tear of the medial head of the gastrocnemius. Ultrasound remains the first line imaging modality, while MRI is the gold standard for comprehensive assessment of muscle injury. Muscle injury classification system such as PAMI have clinical relevance. Connective tissue involvement, especially aponeurosis and tendon, is the main prognostic factor. MRI contribute to return to sport decision making, but should never be used in isolation. Thank you.
Thank you, Dr. Khamis. Our next speaker is Dr. Gitanjali Nanda. She is a consultant radiologist at Mahajan Imaging, New Delhi. She has a special interest in MSK MRI, women's imaging, and pelvic floor imaging. She has been awarded Asian Fellowship by Korean Society of Radiology. Over to you, ma'am.
Thank you for the kind introduction, and thank you for giving the opportunity for this talk. In the next 10 minutes, we are going to talk about toe trauma, the plantar plate injuries, and sesamoid pathology on MRI. The learning objectives is to understand the helical plantar plate and lesser plantar plate anatomy, the corresponding anatomy on MRI, what exactly is turf toe and the mechanism behind it, the findings on MRI in turf toe and plantar plate injuries, sesamoid pathologies, and how to avoid the pitfalls. Why should we know about this topic is because it's a common cause of injury and forefoot pain in runners and athletes, and it is usually clinically overlooked, and MRI can change the management from conservative to surgical. Physiologically, the first MTP joint takes about 40 to 60% of loading force during the normal gait, but in severe athletic activities, it can increase up to 800% of the body weight. So this is a commonly prone area to injury. We do a dedicated forefoot MRI. The sequences taken are PD fat saturated, T1 axial coronal sagittal, and if required, we do the stir and T2 fat sat images in a small field of view, thin slices to 2.5 and 3 millimeters. Let's understand the anatomical components behind the first plantar plate complex. So it consists of the bony architecture made by the osseous framework, the static stabilizers, which are the ligaments, and the dynamic stabilizers. The osseous framework is made by the base of the proximal phalanx, the head of the first metatarsal, and the medial and lateral sesamoids are contained within the broad plate-like structure at the base. So the fibrous cartilaginous tissue makes the ligaments. Like between the two sesamoids, it makes the intersesamoid ligament, and between the heads of metatarsals and the sesamoid, they make medial and lateral metatarsosesamoid ligaments. From the phalanges, they make the metatarsophalangeal ligaments, and then there is a thick band of tissue called as plantar plate. This is supported by the dynamic stabilizers, which are the tendons for flexor hallucis longus tendon, which is the main tendon here, and the smaller tendons are medial and lateral heads of flexor brevis tendon and the adductor and abductor hallucis tendons. So looking the same things on the short axis coronal MRI images and the sagittal MRI images are the best to evaluate these structures. So the medial and lateral sesamoids, the intersesamoid ligament, the flexor hallucis longus tendons, and the ligaments on the sides from the sesamoids to the metatarsal head, and on the coronal long axis view we can see the sesamoidophalangeal ligaments. So we need to see for the integrity of all these ligaments and the signal. Just comparing the hallucal and lesser plantar plates, the function of the first metatarsophalangeal joint plantar plate is to bear the greatest load, and it helps in the terminal stance and the toe off. So the other lesser toe plantar plates from second to fifth metatarsals, they maintain the stability and they distribute the load. So in the first one, it's a complex of plantar plate and sesamoids, and in rest of the toes, it's only the fibrocartilaginous plantar plate. So here we can see the lesser plantar plate going to the base of the proximal phalanx, which is inside of the tendon. So this small area here. And on the short axis images, we can see a hammock-like structure, which is made by the collaterals, accessory collaterals, and the plantar plate on which the flexor tendon rests. So understand what exactly is turf toe. The turf toe term was coined when the athletes shifted from wearing the hard sole shoes to the flexible shoes on an artificial turf. So previously they were running on the ground, and now they are running on the turfs. So the mechanism changes, and this happens when there is a sudden hyperextension injury of the first metatarsophalangeal joint, and it is common in the American football and soccer players. They say that approximately 40% of the players, they have a turf toe injury in their careers. Just trying to explain this with a video here. Could you play the video, please? Yeah. Not running at this one. It's a small video. I just wanted to explain how this happens. So during the push-off, the first metatarsophalangeal joint, it bends. All the pressure comes on the smaller structures of the joint, and these structures break and leads to a plantar plate injury. Yeah, we can go back to the main. So based on this mechanism, yeah, as Dr. Desai said that it's easy for us to grade everything, grade 1, 2, 3. It's like grade 1 is mild sprain with all intact sesamoid and plantar ligaments and everything. Grade 2 injury is partial fiber disruption. So here the player can come back to sport faster. But grade 3 injuries involve full thickness fiber disruption and unstable joint and associated fractures. So here the player has to rest it out a little longer. Let's see some cases. So this is a case where there's all the structures are intact, just edema overlying the structures. So this is a grade 1 injury. I think we are left with more than 5 minutes right now. Yeah, yeah, the last talk of the session. So here we have a fracture of the lateral sesamoid bone with complete disruption of the lateral sesamoidophalangeal ligament, and the medial sesamoidophalangeal ligament is intact. This is a patient with the, we can see edema on the short axis view, but we can see a clear-cut sesamoid fracture on the sagittal images, and there are a lot of edema around the structures. Another case in which there's a fracture of the medial sesamoid bone, which is a comminuted fracture, multiple fragments are there. Here we can see. This is a case of a full complete rupture of the lesser plantar plate. So this both second and third plantar plates are completely ruptured. We should know about the sesamoid pathologies also, like sesamoiditis, stress reactions, and osteonecrosis. It's a little challenging to differentiate between fractures and bipartite sesamoids because they are very common, and 85% of the partite sesamoids are bilateral, and usually we differentiate by looking at the sharp corners, non-sclerotic margins, and irregular edges. And there can be a traumatic diastasis of bipartite sesamoids in a acute trauma setting as well. So here we can, here we can see a bipartite sesamoid with sesamoiditis, and there are secondary degenerative changes happening between the sesamoid and the metatarsal head. This is X-rays showing both bipartite sesamoid and bilateral medial bipartite sesamoids. We should know about the AVN of sesamoids, in which we have a dark signal of sesamoids on all the sequences without bone marrow edema, and this is the 0T sequence, which is corresponding to the sclerotic changes in the medial sesamoid. We should look for the associated injuries as well, like collateral ligament tears for capsular tearing, extensor mechanism, flexor halsus longus tendon tear, cartilage, and bone bruising. In this case, we can see that there is a disruption of the flexor halsus longus tendon, and on the short axis images also we can see that the tendon is disrupted. The last is reporting checklist. We should look for the plantar plate integrity, location and grade of tear, retraction of the ligaments, bone marrow edema, fracture sesamoid status, collateral ligaments, tendon, and cartilage structure. And the take-home message is that high-resolution MRI can change the management for the athlete from conservative to surgical, so we should know about this. We should always evaluate the plantar plate and sesamoid complex as a functional unit rather than individual structures. And a structured MR reporting will help in a complete diagnosis. Thank you so much for your time. Thank you. Thank you.
Thank you, Dr. Gitanjali, for an excellent presentation, completing it in time. That is the end of our session. I think it has been a wonderful session covering the entire spectrum of sports injury imaging, and I'd like to thank all the speakers for giving us the finer points, and for Dr. Nafisa for moderating this session. There is some question, I think. Yeah.
We have to understand that plantar plate is a complex structure which is like a capsule and ligaments and everything. So they say that usually where there is scarring and you see thickening of the ligaments, then you can suggest that there is a fibrosis. Like any other ligament, when we see that it's torn and after that there is scarring. So that is what we can write. But it's a little difficult. It's not that straightforward. That is a different entity. This is, yeah. It mimics, yes. It definitely mimics modern neuroma, yeah.
Hi, excellent presentation, very nice images. Just two questions. Do you do you differentiate between when you're talking about bipartite versus sesamoid fracture? If it's a fibular-sided sesamoid versus tibial-sided sesamoid, does that help you in figuring out whether it's bipartite?
Yeah, so usually medial side is more common, the tibial is more common, and it's helpful to do the X-ray for both the feet. So you can compare from the contralateral side. It helps, yeah.
Okay. The second question was, I mean, obviously this is sports injury session, but have you seen degenerative plantar plate like injuries?
Yeah, when there are associated arthritic changes, we do see the degenerative changes, yes. Yeah. I think it's a longer term sequelae to the same thing.
Yeah. Thank you.
Everybody, this is Dr. Shriram Rajan. He also works with Mahajan Imaging. He's one of the best MSK radiology minds I know. So when I have a problem, I call him. Would you like to add? Would you like to add your own experience about the question that you just asked?
Yeah. So like Dr. Gitanjali was mentioning, sesamoids basically, when we are looking at the entire turf toe or the plantar plate, I really like the way she was talking about it. Like, you have to look at the plantar plate, look at the sesamoids, then look at the collaterals. Usually, if bipartite is very common. The tibial sided bipartite is the only one which we tend to see. Lateral side, if you see bipartite, that means usually it's a fracture. Other thing is, like she was showing, there were some cases in which there is a bipartite, but there might be sesamoiditis. So again, it is symptomatic. One point which is there, which we used to think that turf toe is only seen in, say, sports injuries and in American football and all that. I've started seeing turf toe in even people, like you might see a middle-aged person or the so-called weekend athletes, like a 40-year-old or 45-year-old person who just started off doing marathon running or doing stuff like that. Over time, the plantar plate actually starts degenerating and it can show a tear. So we should be very aware that it's not just a sports injury, it can also be a degenerative kind of a tear. Thank you.
Right, thank you everyone. I'll hand over for the next session to Dr. Vaishali, who's the moderator for that.
So good evening everyone. We'll be starting with the neurography and nerve imaging session. And for chairpersons for this session, I would like to invite Dr. Anbarasu. Are you there, sir? Dr. Natasha Gupta. And Dr. Geeta Karande. We'll be just starting in 2 minutes, just waiting for the chairpersons to come.
So next we have an exciting talk on so the entire session is on neurography and nerve imaging, and the session is going to be moderated by Dr. Vaishali ma'am. So she is the director and head of the department at Apollo Medics Lucknow, and she also is a RSNA fellow. And ma'am is going to talk about the brachial plexus and lumbosacral plexus. Ma'am, over to you. Thank you so much.
Yeah, thank you, Suvinay. So this is a very long topic on which I usually give presentations which last up to an hour. So here, since we are very short in time, I've just kept a very simple approach for you all to follow. So without wasting any further time, let me begin. This is going to be the brief outline of my talk. I'll just be discussing the anatomy and MR neurography very quickly and then show you a couple of good cases. So let's start with the anatomy of the brachial plexus. So the brachial plexus is formed by ventral rami of C5, C6, C7, C8 and T1 spinal nerves. C5 and C6 together form the upper trunk, C7 continues as the middle trunk, and C8 and T1 will join to form the lower trunk. So after the trunks, there are the divisions, anterior and posterior from each side. All the posterior ones will join to form the posterior cord, from where we have the radial and axillary nerves. The anterior divisions of upper and middle trunks will form the lateral cord, from where we have the lateral root of median and median nerves. And the anterior division of the lower trunk will continue as the medial cord, from where we have the ulnar and the medial root of median nerves. These are the terminal branches, and I'll not repeat them again. There are other many minor branches. The important one you might have come across would be the suprascapular nerve, which is coming from the upper trunk. Now, lumbosacral plexus is formed by lumbar plexus and sacral plexus. So lumbar plexus is formed by ventral rami of L1 to L4 spinal nerves, and then the sacral plexus is formed by ventral rami of S1 to S4 spinal nerves. And in between they have a communication which is by the lumbosacral trunk, right, which has contributions from L4 and L5. Now this is a nice schematic which I found on the web, and this shows all these multiple branches of the lumbosacral plexus. Like we have iliohypogastric, ilioinguinal, genitofemoral. The most prominent of these is the femoral nerve, which will run down into the thigh. On the lateral aspect of that is the lateral femoral cutaneous nerve, which you might have heard in context with meralgia paresthetica, and this is closely related to the anterior superior iliac spine. There is another nerve, the obturator nerve, which is easy to locate because it just runs vertically down along the pelvic side wall. From the sacral plexus, the most important is the largest nerve, which is the sciatic nerve, which will come out through the greater sciatic notch. And then there are a couple of smaller nerves like superior gluteal, inferior gluteal, and the pudendal nerve. These are the branches I've already told you about. Now a word about MR neurography. So MR neurography is what we say we use to image the brachial and the lumbosacral plexus and the peripheral nerves. It is just a combination of 2-dimensional and 3-dimensional sequences taken in different planes. Now the 2-dimensional sequences are T1 and T2 with fat suppression. That is the common thing. Why T1? Because T1, you see, fat is best seen in T1. So fat is your friend here when you're talking about nerves. You see the perineural fat planes, which are nicely seen on T1. Then you need a T1 also if you're planning to do a post-contrast study, which we are doing only in infections and tumors, and for fatty atrophy of the muscles. Then T2 with fat suppression obviously makes your eyes go directly to the site of pathology. You can localize, okay, this is the site of pathology, this is the extent of pathology, and also type of pathology. Then there is 3D imaging. So 3D imaging is of different types. What I'm doing is, because I have a basic 1.5 Tesla kind of system, I'm doing just non-nerve selective imaging. That means only fat is getting suppressed. But people who have better systems also have nerve selective imaging, in which both fat and vascular signal is getting suppressed. See, vessels will interfere with your nerves, right? So it's okay, with experience you learn to identify the nerves very well, but if you have this, then nothing like that, very good. And functional nerve selective imaging in institutions where there is time and where you don't have 30 patients lined outside fighting for your number to come, okay? So let's now come to the most important thing before the buzzer rings. So my talk is completely based on NS-RADS. So you all must be familiar with BI-RADS, PI-RADS, LI-RADS. So Dr. Chabra, who is one of the biggest names in nerve imaging, has come up with NS-RADS. He and his team gave this in skeletal radiology in 2022, and that's what this whole presentation is based on. So these are the categories. 0 means incomplete study, so you have to call the patient again. U means unremarkable or normal. NOS, NS-RADS, NOS means not otherwise specified. So you don't have clear things, what you want to know, like clear history, clear examination, or there is something near the nerve without a direct neural involvement. Now coming to the most important thing which you'll use very often, and this is I. I is for injury. It has 5 grades. It is completely based on the Sunderland classification. Actually, they haven't even edited it, but they have just given Sunderland 1 as 1, 2 as 2, 3, 4, 5, same order. The thing to understand here is that with increase in the degree of, the numbers 1, 2, 3, 4, 5, initially it's only the axon which is demyelinated. Then the axon gets disrupted. Then the connective tissue goes. So endoneurium goes, then perineurium goes, and in grade 5, the complete nerve is sectioned. So what's the difference? What does this convey to your surgeon? That management is going to change. So up till 3, it may be conservative, but beyond that, it has to be surgical. There's not going to be any spontaneous healing. Now let's quickly take up these cases. Like this is a patient with left-sided brachial plexus injury. All the nerves are bright and thick, and this is I2. I2 means the nerve is enlarged and there is some hyperintense signal. Now this is I3. I3 means the nerve is even more enlarged than grade 2 and there is some interspersed hypointensity which is all due to fibrosis. So now this is somewhere in between. Management can be conservative, but if not improving, it can go to surgical. Now this is a case of a child who had a direct injection done into the sciatic nerve in a periphery in some CHC around Lucknow. And what happened after that was he had foot drop. So this is I3. The nerve is grossly enlarged and thickened compared to the opposite side, and even there is significant fascicular hyperintensity. This is a case in which there was a motor vehicle accident and the lumbosacral trunk is now showing a nodular thickening, which is a neuroma in continuity. So this is grade I4. And here what's happening is there's complete avulsion of the nerve roots from the plexus and a pseudomeningocele. Here the nerve roots are hanging limp in the cervical region, so complete nerve damage, grade I5. Now the next category important is neural and perineural neoplasia, which is N. So it's like N1 definitely benign, N2 probably benign, N3 probably malignant, and N4 is post-op with recurrent tumor. So not much time for theory, so I'll go to the cases. Like this is a lady who had ulnar neuropathy and very well clearly defined mass lesion, nerve going in, coming out. So this is definitely benign. This was a schwannoma. This was a femoral nerve schwannoma. You can see it's right between the psoas and iliacus, which is the site of the femoral nerve. So N1. But this lesion is slightly more heterogeneous. It is showing some internal degradation like cystic changes or necrosis. It's at the level of the trunk. So this becomes N2, probably benign. Now this is a case of CA breast. So she came with right upper extremity weakness and all the nerves were thickened and hyperintense with lot of peritumoral edema. So this becomes probably malignant, N3. This is a young man who was operated thinking that he has a benign nerve sheath tumor without even a biopsy. And subsequently, within a month, he came back with such a large aggressive looking mass lesion. So this was N4, post-op with recurrent tumor. Now E is for entrapment neuropathy. So depending on the degree, E1, E2, E3, mild, moderate and severe. Mild one has only changes in signal and the moderate one has changes in signal and size, and E3 has further changes in size like proximal and distal enlargement both. This was an interesting case. Like this is a patient who had an acetabular fracture and who had fixation for this fracture. So what happened after that was Within 4 days after the surgery, I'll just finish in 1 minute. Within 4 days after the surgery, he had foot drop. So subsequently, in what we found was that the nerve which was seen was bright, and even in the proximal thigh it was bright. So this is again an entrapment injury. They went in, they operated him again, did a neurolysis, and now the patient is slowly recovering. D is for mononeuropathy, D2 is for polyneuropathy. This is for diffuse nerve lesions. So like a single nerve involved in a case of Parsonage-Turner syndrome. Then you will find many nerves involved in a case of herpes zoster neuropathy. Similarly, in CIDP and Charcot-Marie tooth, multiple nerves involved. So D is simple, one nerve D1, multiple nerves D2. And this is the post-treatment category, which I don't get any cases. Mostly clinicians are following them up clinically. And this is the last thing, because nerves are involved, so muscles will obviously involved. So there's a category for muscles also. M0 normal, M1 edema, then M2 and N3 will be more of edema on fatty replacement and atrophy, and M1 is not otherwise specified. Like here you just have edema-like signal, so this is M1. Here you have lot of atrophy, so it becomes M3. And with that, I've come to the end. I'll just emphasize quickly, remember the anatomy, the protocol. The timing of the scan is important in trauma because you need to wait for 3 to 4 weeks for all the edema and hemorrhage to subside before you do the scan. Clinical data is a must, and teamwork makes the difference, so always interact with your clinician. And thank you all for your kind attention. Welcome to Kolkata next year. Thank you. Yeah. So for the next talk, we'll have to prepone the session of Dr. Ankur Goyal because he'll be taking your quiz after our session. We have to prepone his talk. I'll call you next.
So sorry to Bart. Very sorry. So in the next, no, it's okay, ma'am. Oh, CV chodo.
So
can you please fix this to 15 minutes, 7-minute pay? So actually, I can finish in half a minute if we apply NS-RADS I, the same as Dr. Vaishali discussed to peripheral nerves. My talk is over. So, okay. So I believe you all know the nerve ultrastructure, right? We'll talk about all these layers. So important to know that axons are covered with myelin sheath. Myelinated axons, they are covered by endoneurium. Then these form fascicles. Fascicles are covered by perineurium. Then all these fascicles combined together, they are enveloped by epineurium, and that constitutes the entire nerve. So how many in this hall believe that MRI is best for evaluation of peripheral nerves? No one. How many believe that ultrasound is best? Wow. And how many believe both have their own niche indications? Good choice. So for peripheral nerves, to see directly the nerves, ultrasound is a very good modality, and we know we can go as high frequency as possible depending on how big or small the nerve is and how deep or superficial it is. We know the advantages of ultrasound and MR. Just to give you a glimpse, this is how a speckled appearance of nerve should be, right? The dark structures, they are the fascicles. The brighter structures are the connective tissue, and this bright outline is the epineurium. Okay, the cursor is visible. The same we can see in the longitudinal images as well. And the beauty of ultrasound is that you can scan the entire nerve back and forth right from the axilla up to the palm of the hand. So this image clearly shows that this is not the typical speckled appearance as we expect, right? This is much hypoechoic. What about this? We can clearly see that the nerve is transected. There is end neuroma formation, right? And there is a metallic plate in situ. Similarly here, you can actually see all the layers of the nerves getting transected, right? So whenever you have to take a direct assessment of the peripheral nerves, ultrasound is a very good investigation. But as we know that MR neurography removes the operator dependency, but in a country like ours, the dependency then shifts to the technician or the scanner. So if you have a good scanner, good technician, MRI will be very good, your interpretation will be very good. However, if you don't have that, then probably you'll have to depend more on ultrasound. So for identification of secondary denervation changes and deep-seated areas, MR will score over ultrasound. This has already been talked about. I'll just show you how the nerves look like on MR. So this is the tibial nerve and the peroneal nerve. These are the non-fat suppressed sequences. These are the fat suppressed sequences. If you have to make a lecture, then you will put in some diffusion tractography images, because otherwise practically no one has the time to put the ROIs on subsequent section and calculate these FA values and draw these beautiful maps. One can do volume diffusion weighted imaging, like in this particular case with background suppression, where the abnormal area is highlighted because of the diffusion restriction. The 3D sequences ma'am has already discussed. So 3D space or 3D T2 weighted sequence is something which every one of us can do, right? We don't need anything special for that. For brachial plexus preganglionic, you need to add a Fiesta or a heavily T2 weighted sequence. If you have a good scanner and these sequences are available, then try to do one of these sequences. This is a gradient echo sequence, and this is a diffusion weighted PSIF, that is the reverse FISP sequence. So just to give you an example, this is how the spatial resolution of these 3D sequences is. And this is how the normal T1 and T2 weighted images will look like. So this is the median nerve. You can see corresponding to the spectral pattern we see on ultrasound. So the fascicles appear dark and the connective tissue appears bright, right? And this is the T2 space maximal intensity projection image, which shows you that the nerve is disrupted here. So that is the advantage of 3D sequences. You can follow the course of the nerves. You can look for the areas where they are abnormal. This is again an example of volume diffusion weighted image showing you a neurofibroma arising from the ulnar nerve. This is contrast enhancement is usually required only if you are suspecting a tumor to demonstrate the enhancement. And this is an example of how FA values are reduced in carpal tunnel syndrome. So normally the FA value should be close to 0.5. If they are less, that means there is disruption of the fascicles and it will be shown in a different color format. Okay, let's leave this. So they have their own pros and cons, and remember to use both the modalities whenever in doubt, and they are actually complementary rather than competitive. And do not forget to resort to the radiographs as well as sometimes doing a CT to know where the fracture happened, where the metallic instrumentation is done. Is there any screw which is actually penetrating the contralateral cortex and maybe impinging on the nerve? So that is important information which we can get on radiographs. So the role of imaging is to localize the exact site of injury, to grade the injury. Remember, if the requisition form is query radial nerve injury, our report cannot read, yes, findings suggestive of radial nerve injury. That is a useless report. We need to add value to our report so that there can be some management repercussion based on our report. So to grade the severity, identify any treatable cause, and for post-operative assessment as well as follow-up. So let's understand what will go wrong in the nerve once it is injured. So it can show hypoechogenicity, right? Because of edema, it will be hypoechoic. It can show enlargement of the entire nerve or the fascicles. There can be loss of the fascicular appearance. There can be increased echogenicity within the nerve or outside, and there can be increased vascularity in the active phase. What about the indirect signs? So there can be muscle changes which can be appreciated on ultrasound as well, although we are much more comfortable interpreting them on MR. The same things will be visible on MR. So the hypoechogenicity on ultrasound will correspond to hyperintensity on T2 weighted images. Nerve enlargement, fascicular changes, everything can be seen. So this ma'am has already discussed neuropraxia, axonotmesis, neurotmesis. Those are the grades of injury. Then Seddon classification was the first classification. Then Sunderland tried to make our life even more difficult. Instead of the 3-tier grading, now it was 5-tier grading. So we actually can't see the myelin. We cannot see the axons. We cannot see the endoneurium. But what we can see and how we can grade the injury, let's see. So this was an article in 2014 by Chabra et al. Who tried to tell how the different layer involvement will give rise to structural changes on MR for the radiologist to interpret. and let us see. So what are the imaging features which will help us to classify? If there is just edema, that is grade 1. If edema is associated with bulkiness, that is grade 2. If the fascicles are thickened, grade 3. If the fascicles are disrupted, grade 4. If the entire nerve is transected, that is grade 5, right? So we have to adapt all these ultrastructural changes to the things which we can see. And this is a simplified method. And as ma'am said, NS-RADS I is there. And in that, the muscle denervation changes are also described. So this is the key image which you should take from this 15-minute lecture, that if it is only edema in the nerve or the nerve is normal, no muscle changes, it is grade 1. The muscle changes will start from grade 2 onwards. In grade 2, the muscle changes are only transient. They will eventually rectify. There will not be any atrophy, but they will leave aside some sequelae grade 3 onwards. So if there is nerve enlargement, it will be grade 2. If the enlargement is more than 100%, it is grade 3. If there is NIC, that is neuroma in continuity with loss of fascicular architecture, it is grade 4. And a complete discontinuity is grade 5. So this is the simplistic approach which you should try to adopt in your daily practice, and let us see few examples. So clinically, patient had radial nerve injury on ultrasound, normal, abnormal? Normal. This is the speckled pattern. We can see the hypoechoic fascicles, we can see the connective tissue. So this is grade 1 injury. What about this? No muscle edema and just edema in the nerve, T2 hyperintensity. So this is grade 1, very good. What about here? We don't see the fascicular appearance, so there is definite edema as well as there is bulkiness. So this is not grade 1. This is a higher grade injury. The same we can see on MR as well. So we can see subtle edema, right, in the distribution of the nerve. And there is bulkiness in addition to edema in the nerve. So this is grade 2. What about in this case? We start seeing fatty atrophy of the muscle in the leg, right? So this cannot be grade 2. This has to be 3 or higher based on the muscle changes. And we see there is hypoechogenicity. See, we can't make out the outer extent of the epinurum. There is so much increased perineural echogenicity. So this is grade 3 injury. What about in this case? Again, this is the normal fascicular appearance which we should have seen, and here we don't see any fascicular appearance. There is bulkiness, there is edema, and bulkiness is quite much. So it is more than 50%. So this is grade 3 injury. The same as you can see on MR. So there is enlargement of the fascicles in grade 3. If we lose the fascicular pattern, that will become grade 4 injury. What about in this case? So this was a penetrating injury. You can see the penetrating tract. So here there can be like equivocal, whether the fascicles are disrupted or not, right? So at least a grade 3 or a 4 injury is happening in this particular case. So this was electrocution injury, and you can see these are the normal fascicles. These are the normal fascicles. What is happening here? Crisscrossing of the fascicles, loss of the fascicular architecture. Once the fascicular architecture is lost, it becomes a grade 4 injury. So this is a grade 4 injury. This is a post-total knee replacement case where we can again see the fascicular architecture is completely lost, and this is the classical appearance of a neuroma in continuity, right? You think that there is a neuroma, but you don't see the retracted edges. So this is neuroma in continuity, also known as grade 4 injury. Now this is a very interesting case. This is the sciatic nerve, and here it is supposed to give off 2 branches, the tibial and the peroneal. But we see the tibial, we don't see the peroneal. Instead, we see an amorphous tissue in that location. So this is like a shearing injury at the origin, at the bifurcation of the sciatic nerve, where it is a very high grade injury. So let's see that in axial. So in this cine loop, this is the sciatic nerve, the speckled pattern. Remember, that is the largest nerve, so easiest to see. And this is the peroneal nerve. See the tibial nerve and see the peroneal nerve. You can't make it out separate from the adjacent muscle. There is nothing in it. No fascicular architecture can be seen. So this is a very high grade injury, which is like a shearing injury from the origin of the peroneal nerve. The same patient also had a different site of injury corresponding to the fibular fracture, as we can see here, complete loss of the fascicular architecture and increased size of the nerve as well. More examples. So this is again a neuroma in continuity. This is the fascicular architecture proximally and distally. This is how the normal nerve should have been on the contralateral side, and the same findings were confirmed on surgery as well. How does it look on MR? So this is how it will look on MR. So there is no gap, no discontinuity, but there is a neuroma in continuity. So bulkiness of the nerve with disruption of the fascicles, like in this particular case, but no retracted edges. And what happens when there is complete transaction? So there can be retraction and formation of end neuromas, like in this particular case. So how it will look on MR? There will be lot of edema, atrophy. So here you can see both the median nerve and ulnar nerve, they are ending in ball-like structures. So these are end neuromas. And if you draw oblique coronals or sagittals, you will be able to see the proximal neuroma as well as the distal neuroma, and you can actually calculate the size and the size of the neuroma as well. The same thing, so how the grade 5 injury looks on ultrasound. So these are the retracted edges. So you can see this is the ulnar nerve, this is the median nerve, same case, and you can calculate the distance and the size of neuromas as well. More examples of grade 5 injury. So here in this case, you can see that the fracture has been fixed with a metallic plate, but no one looked at the nerve, and there was grade 5 transaction of the nerve as well. This was after a penetrating injury. This is the tract of the penetrating injury, and we can see the retracted nerve ends. The same if we try to do a 3D coronal image, so we can see the radial nerve injury. This is the transaction, and this is the gap in grade 5 injury. So just to summarize, usually the nerve injuries follow an inside out pattern of injury. So it starts from inside, goes on till outside. Till the time connective tissue layer is not involved, there will be good regeneration and good recovery of function. So grade 3 onwards, the connective tissue layers are involved, and that is the problem area where the spontaneous recovery will be incomplete, and usually some form of surgery, be it external neurolysis, internal neurolysis, or a nerve transposition, something will have to be done for the recovery of function. So in grade 1, it can be normal. In grade 2, it is bulky with edema. Grade 3, even more bulky. Grade 4, disruption of the fascicles, and grade 5, disruption of the epineurium as well. So to conclude, both ultrasound and MR are complementary modalities. Use both of them to increase your diagnostic confidence. Take a look not only at the nerves, but also at the muscles which are getting innervated. Follow a standard nomenclature. Look at both the direct and indirect features. If you want to read more, you can refer to any of our articles on entrapment neuropathies as well as on traumatic nerve injuries. And of course, you can go back and read Dr. Avnish Chavda's article. And this was what just the AI generated, that in near future, we'll have a scoring system to prognosticate, where we can include electrophysiological studies, the imaging studies, and then we can probably assign a prognosis to the patient. Thank you.
And I think if there are any questions, we'll have to take them at the end, or you can catch him when he's conducting the quiz, because after the quiz, because otherwise we'll be late. Okay, so for the next session, I hand over to Dr. Geetanjali.
I would like to invite Dr. Jun Yong Jung, Anyanseo, and he is affiliated with St. Mary Hospital, Seoul, and he's got more than 100 peer-reviewed articles, winner of multiple awards, Outstanding Researcher Award in CMC Radiology. So I hand over the presentation to you, sir.
Thank you for the introduction, and we are on a tight schedule, so I try my best to finish my lecture before the bell rings. So this is the first, today my talk is going to be about the technical part of MR neurography and how it's advanced nowadays, and then we can expect the future. This is the first neurography images which was acquired 30 years ago, and there is a, you can see the fascicular pattern of the nerve, and it's bright, and also they make the MIP image from this images. So the basic concept of MR neurography has been built in 3 decades ago, and since the 3T MR machine has been introduced, the neurograph has been developed in a more clinically usable technique, as shown here. And 2D imaging, actually, the basic imaging sequence that we can evaluate, so high resolution fast pinnacle sequence with sufficient signal-to-noise ratio and signal intensity and architecture of the peripheral nerve can be checked. And it's orthogonal to the longitudinal course of the nerve. And non-faceted T1 or proton density weighted imaging and the fluid sensitive sequence orthogonal to the peripheral nerve is the basic sequence, and 4 to 5 millimeter thickness with a 10 to 20% interslice gap would be the balancing, the partial volume, minimizing the partial volume effect and the signal to noise ratio acceptable with acceptable range. But the 3D imaging would be the most advanced part of the MR neurography, and the isotropic resolution around 1 millimeter cubic millimeter would be the improved precision in nerve localization and also capability of MPL and MIP as shown here. We can see the thickened axillary nerve, and we can see this course and like a neurography mapping as shown here. And we also, the technology converged toward the nerve selective imaging, which means the enhance the nerve signal itself and also suppress the vessel signal and as well as a robust vessel suppression. So we can divide the 3D imaging into GRE based and 3D fast pinnacle based images, but I'm gonna more focus on the 3D fast pinnacle sequence. Because the gradient echo is very effective suppressing the vascular signal, but the signal of the nerve itself is not stand out compared to the muscle as compared to the 3D star space in the right side. And you can see if we make the MIP images from the 3D sequence, and yeah, the nerve signal is not as bright as the 3D fast pinnacle based sequence. So 3D fast pinnacle sequence actually employ the variable flip angles and with a specially designed tissue optimizing, and also it decreases the SAR and simulate the target tissue contrast like a 2D fast pinnacle sequence. But it still have a challenge. It has a longer scan time, edge blurring, suboptimal tissue contrast. But now it evolved into a more acceptable ranges. So 15 years ago, the 3D sequence was like this, but now, yeah, at present, the 3D pinnacle sequence has more robust fast suppression and also the vessel suppress better. The fast suppression technique, as you well know, we have a very diverse option, but for the neurography, which has a very like a brachial plexus, it has a robust B1 insensitive technique, so we employ the star or Dixon. But star still have a limitation in the brachial plexus because the star only effective for suppressing BJ or inhomogeneity, but in this area, B1 inhomogeneity is also we have to deal with. So recently, the C foci, which stands for C-shaped frequency offset corrected inversion, and which optimized for the both B0 and B1 inhomogeneity. So as you can see here, the same patient, it completely suppresses this area of inhomogeneity in the fat inhomogeneous suppression, and they clearly visualize the peripheral nerve to the end. So we can compare the two types of stir sequence. The conventional stir, still the leg of fast suppression here and here, but the C foci stir sequence homogeneously suppress the fat shown. And another fast suppression technique that recently developed is a fast Dixon. Dixon needed more time because it needed two different subset of the fat, like in phase and out of phase. But the fast Dixon acquired the image in a same echo train. So two opposite echo and one in-phase echo, so it doesn't lengthen the total scan time. So left side is conventional stir, but the right side is a fast Dixon technique. So you can see it more homogeneously suppresses the fat as shown, and compared to the right left side conventional stir space. And also the stir, even the C4 size stir, it suppresses normal to a certain extent, but the F. Dixon preserve the signal from the peripheral nerve, so it improves the fat suppression as well as preserving the normal tissue signal. And now let's move on to the vessel suppression. The gadolinium enhancement make the vessel similar to the fat signal progress. So stir simultaneously suppress both fat and gadolinium in the vascular lumen. That's how many institutions use the gadolinium enhancements to suppress the blood vessel. So if we compare the both images, the vascular suppression is more robust with the gadolinium, and it's more significantly suppress the vessel, where the stagnant vessel, slower flowing vessel in the in lumbosacral images, as shown here. Yeah, it's very effective to suppress the vessel, but because it also suppresses the pathologic enhancement of the vessel, it rather enhances this tumor infiltration. It suppresses the infiltrative portion of the nerve, so it's a significant. It suppresses the vessel well, but it also suppresses the pathologic nerve. So we approach without gadolinium. Previously the MSD, which employs the diffusion-weighted gradient, it suppresses vessel, but it's still ineffective to suppress the slow flow vessel. So now we employ the Dante sequence, which is famous for making the black blood imaging in our vascular imaging. It uses the alternate the pulse, and it's more robust to suppress the very slow flow. So you can compare the MSD and Dante here in this vessel. The peripheral has a slower vessel speed, but the Dante completely suppresses the slow flow vessel as shown here. And yeah, it's also effective in the lumbosacral images. And now we move on to the deep learning reconstruction. Now we employ the physical basis, the iterative reconstruction rather than the unit-based one as the earlier stage the deep learning reconstruction is applied. So you can compare how the SNR was improved, the traditional star sequence, and the MIP images shows us a more better SNR and CNR for visualizing the nerve, and it's better with the lumbosacral images. You can see more clearly visualized the sciatic nerve. And
we would request you to wind up. We are running short of time for the quiz.
Yeah, but it's only less than 10 minutes. Yeah, so okay. I move on to the diffusion tensor imagings. Yeah, because it's one of my topic. And so the diffusion tensor, we capture the dominant flow in the dominant direction of the wave. So we acquire the fractional anisotropy. It's a number. It's a measure between 0 and 1, and axial diffusivity, which is dominant directional diffusion, and radial diffusivity is orthogonal diffusional. So we apply that technique to the large nerve like a median and sciatic nerve, and most of the pathologic condition, the fractional isotropy decrease while the mean diffusivity increase. So this is the case. The conventional image shows a similar signal when diffusion weighted image and DTI shows a standout signal compared to the normal side. So, and fractional isotropy has a sensitive measure of the pathology, and the tractography we can trace the structural integrity. And its potential is to monitor the peripheral nerve healing. So as the nerve recovers fracture fractional anisotropy gradually normalize, and RD and MD gradually normalize, but still have many challenges: long scan time, low SNR, and susceptibility artifact, and also have a limitation in reproducibility depending on the protocol. So summary, our 3D FSA sequence, we converge more novel selective. So we have a robust fast suppression technique these days, and also Dante is very effective without contrast enhancement. And the sampling pattern is improved with compress sensing and CAIP sampling pattern, and now the DTI, the monitoring peripheral nerve healing is a very promising technique to monitor the peripheral nerve healing. Yeah, thank you for your attention.
Thank you so much for the presentation. And for the next session, I'd like to invite Dr. Harmeet Kaur. She is additional professor at Department of Radiodiagnosis in AIIMS Bhatinda and has multiple presentations and papers to her credit. She's also been a guide and co-guide for 20 thesis dissertations in her institute. So over to you, Dr. Harmeet.
Thank you, ma'am, for kind introduction. A very good evening to all present here. So I'm grateful for this opportunity. I'll be speaking on topic ultrasound and MRI approach to peripheral nerve sheath tumors and their mimics. So this is a roadmap of my presentation. We'll be covering anatomy, which Ankur sir has made my job very easy, so I will not go much into details. Then we'll see imaging protocols, how to diagnose peripheral nerve sheath tumors, how to differentiate benign and malignant lesions, their tumor mimics, and at last we'll be seeing the diagnostic algorithm. So sir has already covered, but I'll like to emphasize the importance of knowing this hierarchy of these 3 protective codes, because if we know the anatomy well, only then we'll be able to see pathologies on our CT, MRI or ultrasound. So why this ultrasound it is important? Because it is actually high resolution imaging. It is real time, cost effective, easily available modality, and it simply helps to see the continuity of the lesion with that of the nerve. And also if we want to do biopsy, ultrasound helps in guiding the biopsy. So we have already covered that this nerve being a fascicular structure, it gives honeycomb appearance, alternate layers of hypoechoic and echogenic because of these fascicles and these fibrous coats of perineurium and epineurium. And also on color Doppler, we can see vascularity in case of nerve sheath tumors. MRI, yes, it is a gold standard for soft tissue lesions, and it helps in surgical planning. Also, it is beneficial in deep-seated lesions, especially acts as a screening tool in cases of neurofibromatosis 1, where multiple neurofibromas are present. This is a protocol, what we follow in our institute. This T1-weighted imaging, it actually helps to know the anatomy of the nerve, and fluid-sensitive sequences, T2 and FAT-SAT sequences, they helps to detect the early pathology, and neuromas and neurofibromas and other nerve sheath tumors, they can detect it well in these fluid-sensitive sequences, pre and post-contrast T1-weighted imaging, and then diffusion-weighted imaging in cases of to diagnose malignancy, and 3D isotropic, of course, being it gives a fine detail, so this sequence is also important. If available, we can apply. It is a WHO classification of nerve sheath tumor. This is a long list of benign and malignant lesions, and out of this, the schwannoma is the most common benign tumor, followed by neurofibroma. And in the malignant ones, we can see the malignant transformation of already pre-existing schwannomas or neurofibromas. So we'll be seeing them in our subsequent slides. So this is the most important slide of my presentation. These are very important classical imaging signs which we need to know as a radiologist, as a resident, because if we know how to see them, only then we can diagnose them and we can differentiate benign and malignant. Like this is the tail sign. We can clearly see a lesion, a nerve entering into the lesion and exiting the lesion, and the tail can be seen at proximal and distal aspect of the lesion. So it is actually tells us about that the lesion, it is neurogenic or neural.
the split fat sign. It is seen on T1 weighted images in which a rim of the normal fat, it is seen along the poles, or it can be seen draping over the lesion. So this again is it actually represents the benignity of the lesion. Target sign, it can be seen on the T2 weighted images in which the central T2 hypointensity that can be seen because of the collagenous tissue and with the surrounding periphery of the hyperintensity, which is due to the myxoid tissue present within the nerve sheath tumors. And fascicular sign may be again seen on T2 weighted images and fluid sensitive sequences. So it represents the swollen fascicles. So we can see the swollen fascicles within the lesion. Now first of all, schwannoma, as the name suggests, it is a proliferation of Schwann cells. So I would like to highlight here that the Schwann cells, this type of the tumor that is confined within perineurium. So because of its location, we can see only some of the fascicles and or their perineurium it is affected, while rest of the fascicles they are spared. So we can clearly, a surgeon can clearly enucleate the schwannoma, while neurofibromas they can't be enucleated. So it is important to convey our message to our surgeons that this lesion, whether we are dealing with schwannoma or neurofibroma. So clinically such patient presents as slow growing palpable lesions. So Tinel sign it is positive. We can see that the schwannomas, they are hypoechoic and capsulated, and some fascicles they can be seen draping along the posterior aspect of this lesion. On MRI, again we can see the continuity of the nerve with this. Target sign can be seen, and the heterogeneous or intense contrast enhancement is noted on MRI. This was the case in which our patient had a progressively increasing or the gradual swelling present over the medial aspect of the right thigh, and we could trace the continuity of this lesion with the obturator nerve. So it was a case of another type of ancient type of schwannoma in which they may present as they may look as malignant lesion on imaging, but they are generally benign type of lesions, this ancient type of schwannoma. The neurofibromas, they actually these type of lesions grow along the nerve fascicles. So no part of the nerve can be seen at the level of the lesion. So these are of three types: localized, diffuse, or plexiform. The localized ones are just like schwannomas, but these are central lesions. But schwannomas, they are the eccentric lesions because they arise from perineurium. So they grow eccentrically, while neurofibromas, they are centered within the nerve. So that's why no part of the nerve is spared at that level. The next type of the neurofibroma are the diffuse one. Usually they are seen along the cutaneous nerves of the skin and the subcutaneous tissues. So they appear as a sheet of the thickening of the skin and subcutaneous tissue, like in these cases we can see. And another entity is plexiform neurofibromas. It is 100% pathognomonic of NF1. So this type of bag of worm appearance, it is seen along the major plexus like brachial plexus or lumbosacral plexus or the major nerves. And also we can see the remodeling of this sacral foramina in such type of lesions. So we have covered how to differentiate neurofibroma and schwannoma, and the main highlighting point is that the schwannomas are the eccentric, while the neurofibromas are the central lesions. Now some rare type of lesion, that is a perineuroma, in which the long segmental fusiform thickening of the nerve can be seen. Other types that the hybrid types can be seen, in which combination of neurofibroma or schwannoma may be seen, but they can be proven only on histopathology. And this is an interesting entity, the neuromuscular choristoma, in which the presence of the normal skeletal tissue may be seen ectopically within the nerve. So in this entity, we can see this is a subcutaneous fat. The nerve is also fascicular structure, shows fibrillary pattern, while the skeletal muscle also shows this type of pattern. So we also should be aware of this entity, that it also exists, and it may be sometime associated with the desmoid fibromatosis in case if it is operated or biopsy is done. Now coming to the important part, that is the malignant peripheral nerve sheath tumors. So we should be aware of the red flag signs. What are those signs? when the pre-existing lesion, like a neurofibroma, is already present in a patient with the NF1, and if that lesion, it is rapidly increasing, the patient is having pain, and the lesion, it shows ill-defined irregular margins, heterogeneity present, or the peri-lesional edema, it is present at proximal or distal poles, and the diffusion restriction, if the ADC value falls within the range of malignant lesions, we should be skeptical of malignancy developing within a benign lesion, which is very much common in this neurofibromatosis 1 neurofibromas. So in this case, a patient presented, this young lady presented to us in our department. So she was a known case of NF1, and we could see the multiple neurofibromas were present in that lady, but she presented because of this acute onset of pain in popliteal fossa, and we could see in this proton density sagittal image the heterogeneous lesion was present, having all contents. The lesion was having hemorrhage, fluid levels, cyst, and on this we can also see the margins are somewhat indefined, and perilesional edema was present in this lesion. Like in the post-contrast enhancement, clearly we can see the other lesion, it is not showing any enhancement, while the lesion where the malignancy was being developed, it was showing heterogeneous enhancement. And this patient also had the brain metastasis, so it was a case of malignant transformation of neurofibromas. So the teaching pearl is that in case of NF1, as a radiologist, we should not only report that the neurofibromas are present. We need to look for all neurofibromas which are suspicious, their margins, everything should be reported, and serial growth should also be mentioned in our reporting. Then the neurolymphomas, again the nerve can be thickened, heterogeneous, or show enhancement. Similarly, the chloroma, in this neurolymphoma, but this type of picture can be seen where the other features of lymphoma may be present in the body. Similarly, in chloromas, it is seen in a patient of leukemias where the nerve can be thickened and show heterogeneous enhancement. And ma'am has already shown that the metastasis can be involved, like in CA breast, ma'am showed that the nerve may be thickened. Now the role of diffusion weighted and DTI in this case, that the fibers, they are actually spared in case of benign lesions, but the fibers, they are distorted and infiltrated in case of malignant lesions. So sometimes neurosurgeons, they want to know whether the fibers tracts are spared or not. In those cases, DTI plays role. So just a word about non-neoplastic mimics. Traumatic neuroma has been already covered by Dr. Ankur, that the neuroma in continuity may be present in cases of trauma, or end bulb neuroma may be present in nerve transaction. Morton's neuroma, yes, it is entity where there is perineural fibrosis. Classical location is second and third intermetatarsal space, where this neuroma looks like this lesion, hyperintense lesion on fat side sequences. Fibrolipomatosis entity, where fat, it is proliferated along the nerve. Most of you must have seen as this classical type of coaxial cable appearance. And last is intraneural ganglion, where the cystic lesion, it is seen within the nerve because of some articular nerve from the joint. It actually reaches up to some major nerve around that lesion. Like in this case, this ganglion cyst, it is developed in relation to common peroneal nerve. These are management paradigm given by this European Society guidelines regarding when to do biopsy or not to do biopsy. Usually these benign lesions and mimics should not be biopsied. So summarizing here, that in case of any lesion, soft tissue lesion, if we are suspecting any lesion of neural origin, we need to see whether it is neural or not. That's how can we see? We should see the location of the lesion, whether it is eccentric or central. If eccentric, it is schwannoma. If central, it will be neurofibroma. And we should see the other signs which I have already covered, that target sign, benign signs, and we should also rule out those red flag signs in case of pre-existing NF1. Thank you.
Thank you, Dr. Kaur, for your very comprehensive and lucid presentation. We can't take the questions right now for the sake of time. I would like to call upon Dr. Anuradha Janardhan. Dr. Janardhan is affiliated with Gleneagles Hospital, Kuala Lumpur, Malaysia, and she heads the Musculoskeletal Special Interest Group for Malaysia. Over to you, ma'am.
Good afternoon, everybody. Okay.
I have my talk made easy because a lot of things have been covered, so I'm going to go through this very, very quickly. Okay, so simple definition of what an entrapment neuropathy is. So this is nerve compression syndrome caused by structural compression at anatomically vulnerable sites, leading to motor and sensory dysfunction. So most clinical presentations would be weakness, sensory deficits, and pain along the nerve distributions, okay? So in these sites, what happens is nerves get compressed with tight fascial either compartments or any kind of anatomical transitions. So the diagnostic challenge here is to get knowledge of the nerve anatomy, the compression sites, and basically the nerve groups going to be involved, okay? So I'm not going to deal with the central nerve entrapments that have been already covered. You've got your brachial plexus, your lumbosacral plexus, and all that. So I'm going to basically talk about a few of the peripheral nerves that I see in my daily practice. So most common that I do is median nerve. Everybody knows about the carpal tunnel, but nowadays everybody wants to look at the lacetus fibrosis, which is basically in the proximal forearm. So this one, basically, we use dynamic forearm ultrasound, okay? So when I do my ultrasound of the forearm, I tend to look at these three nerves, the median nerve, the ulnar nerve, and the radial nerve, and we use basically dynamic imaging to look at the compression. Sciatic nerve, like we saw in the lumbosacral plexus, a lot of people tend to do pelvic MRIs nowadays. We look at the piriformis muscle thickness because we say that if there is any hypertrophy of the muscle, it can cause compression of the sciatic nerve at that point, okay? And then the more peripheral nerves would be posterior tibial nerve, that's in the tarsal tunnel in the ankle, together with the sural nerve, which is on the lateral side. The common peroneal nerve, which will give you a foot drop, usually seen with fibular head fractures. And then the shoulder, we see suprascapular nerve, which can either be at the suprascapular notch or the spinoglenoid notch. So this will cause either denervations in the supraspinatus or the infraspinatus muscles, or both, depending where it is. So this is the carpal tunnel. So I don't know whether you can see this very clearly. That's the median nerve. Okay, so this is post-retinaculum, meaning that is distal to the flexor retinaculum. So this is already in your proximal palm level. And then you see this is pre-retinaculum. So this is before the flexor retinaculum, which means it's your wrist level. So you see a very enlarged median nerve, as you can see, that one. On longitudinal axis, you can see this is proximal. So you get a thickened nerve flattening beyond this, okay? So when you do this extended wrist, you see the nerve here. This is a very thickened flexor retinaculum, you can see. So when I flex the wrist, you can see the flattened median nerve here. You can see all the flexor digitorum tendons are already crowded here, and the nerve gets compressed. Now, this is in the proximal forearm. So generally what I do is, most of the time, I ask patients to just clench their fists. So this causes nice compression of your muscles in the forearm. So you see the nice rounded shape of your median nerve here, and with the clenched fist, you can see this flattening. I don't know whether you can appreciate that. Can you see that? Okay, very good. So this is one of the classical ones that I have. I have so many because I do about 5 or 6 of this a week. So I've got a very aggressive hand surgeon, so that's why. Now, ulnar nerve in the cubital tunnel, we see this anconis muscle here. That's the ulnar nerve. So sometimes we get to see this thickened ulnar nerve. So this is a neuritis. This is not so much entrapment, but there is a neuritis. So sometimes problem may not be in the forearm. It may be in the cubital tunnel, okay? Now, sciatic nerve, okay. This is the typical T2-weighted axial MRI. You can see the thickening of the piriformis muscles here bilaterally. So you can see this side, the left one is thicker than the right. We take up to about 1.5 centimeters as a cutoff to say whether it's hypertrophied or not. So you can see this one is 2.3 centimeters, so we say it's thickened. And most of the time it corresponds to patients' symptoms, you know, where they present with sort of sciatic nerve impingement. This one again, you can see almost 2.5 centimeters here. This side is about 1.6, so borderline. And this is the coronal section, you can see thickening on this side compared to the other side, okay? I don't have cases of tarsal tunnels. I just wanted to show you where to look. So this is where we look for the tarsal tunnel behind the medial malleolus. So these are your Tom, Dick, and Harry tendons. And here you can see the posterior tibial artery vein, and that's the nerve. And the sural nerve is on this side, just behind the lateral malleolus and adjacent to your peroneal tendons. It's here. Okay, so this is where we will look for this. Suprascapular nerve. Okay, this one is a huge suprascapular cyst here. So this is where you have denervation in your supraspinatus muscle. This one is a spinoglenoid cyst causing infraspinatus denervation. You can see the edema in the muscle here. So the difference between the two. So depending on where the anatomy is, where the compression happens, you find the effects in the muscles. Now, this has been spoken of many, many times, so I'm not going to maybe elaborate too much on this. Basically, we use both, okay? The peripheral nerves, I find ultrasound much better, and MRI is good for the deeper vessels, deeper nerves, and yeah. So this is a nice chart I saw that, basically tells you the difference. Again, repetition. So sequential imaging, this is where we say we start with ultrasound, then you move on to MRI, and then basically the complex cases you move on to other things, like what was said before, like DTI, advanced ultrasound with elastography and neurography, basically. So clinical context guides imaging interpretation. I think this cannot be emphasized enough, because I don't know how it is in your hospitals, but in my place, I have orthopedic surgeons who give me standard pain and swelling. I don't even know where it is. Okay, that's a request form. So it's up to us to find these things. So I keep telling them I need to know which part, lateral, medial, so whatever it is. But yeah, I have to argue with them, and they say, I don't have the time. You all don't have the time. Anyway, so recognition of anatomical variance, mimics, and true entrapment ensures accurate diagnosis and appropriate management. So diagnostic confirmation must correlate with clinical distribution. So electrophysiologic confirmation enhances diagnostic certainty. Images reveal any structural causes, okay? So now mimics recognition. Sometimes a radial tunnel can mimic lateral epicondylitis. So we have to be very careful about what we see and what we say. And imaging basically will identify structural compression. Red flags will be any sort of rapid symptom progression, bilateral involvement, unusual pain distribution, presence of systemic disease, and if there's any mass or inflammatory process. So these things basically rule out entrapment syndromes. Okay? That's it. I'm done.
Thank you so much for wrapping it up in time. And we are all delegates. I think if we've just managed to finish in time, you can join in Hall A for the quiz. And I hope if you have any questions, all the speakers are here till night, so you can, just grab hold of them and ask your questions. Sorry about this, but we were running late. I think we can take a picture of all the speakers. So sorry I had to rush. I'm really sorry about it, but I was feeling miserable doing it, but couldn't help it. Yes, survivor. Yes, that's the better word. Oh, okay. Just turn this. Can you switch it off? Switch off the projector, please.